Okay, we will call the meeting to order. We will start off with roll call to establish a quorum.
Ms. Esri?
Yes.
Ms. Bowler?
Here.
Here. Dr. Nunez? Dr. Nunez will be delayed. He'll be here hopefully around 10:30. Ms. Pulowski?
Here.
Mr. Felt?
Here.
Dr. Solocito?
Here.
Dr. Sullivan? Dr. Waterhouse?
Here.
We have a quorum.
Okay, next we'll go to public comment on items not on the agenda. Is there any public comment in the room? Seeing none, moderator, would you please open it up for public comment online?
Absolutely. We are now open for public comment via WebEx. If you'd like to make a comment for items not on the agenda, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment for items not on the agenda. Seeing no request online, do you wish to continue with the agenda?
Yes, thank you. Okay, item 3, review and approval of July 15th, 2025 committee meeting minutes. I know Dr. Waterhouse had submitted some changes. Do we have those?
Yes, I submitted a change regarding the VCPR and the problem-oriented,
Yep, and I think Ms.
have
Pulaski
anything?
also submitted some. So Justin is sharing the track changes on the screen for you. So Justin, if you don't mind going to the first change, and then we can kind of walk through the changes that were made. All right, so the first change, I think there's a few of these where Ms. Pulaski's name was misspelled, so we have corrected that. There it is again. Here, I think this is where you were referring to Dr. Waterhouse. So we added a statement in there that it was noted that Oregon is the only other state that has the condition-specific VCPR requirement. So that was added. And then we completed the last half of your last name. That's it. And that was all. Any other edits?
If there are no other edits, can we get a motion to approve the minutes?
motion to approve. Second.
Okay, any public comment from the room? Seeing none, moderator, would you please open it up for public comment online?
We are open for public comment on the minutes. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. Once again, for those just joining us, this is comments on the minutes. We're going to take just a few more seconds to see if we have a request for public comment on the minutes. Seeing no request, you wish to continue with the motion?
Yes, thank you.
Ms. Esri?
Yes.
Ms. Bowler?
Yes.
Dr. Decken?
Yes.
Dr. Nunez? Dr. Nunez is absent. Ms. Pulowski?
Yes.
Ms. Chappelle?
Yes.
Dr. Solocito?
Yes.
Dr. Sullivan?
Abstain.
Dr. Waterhouse?
Yes.
Motion carries.
Okay, agenda item 4, the committee chair report. I'll give you guys a brief overview of what happened at the last board meeting and some of the packages that are moving through. So at the July board meeting, I provided a brief overview of the agenda items that did not require board action. Of those items, 2 were referred back to the MDC for further evaluation. One was the condition-specific VCPR and the VCPR time limit, and the other was clinic staff signing on behalf of treating veterinarians and the types of signatures that are accepted. It was requested that we await a response from the medical board before proceeding, and if no adverse feedback is received from other boards, the MDC will explore the development of outreach materials. Following that, I presented Agenda Item 5B, the recommendation to amend Assembly Bill 1502 for BPC 4841.5 concerning RVT education pathways. The board voted to ratify the proposed amendments to 4841.5 as outlined in the June 25th version of AB 1502. We then addressed Agenda Item 5C, the recommendation to initiate a rulemaking to amend CCR Title 16, Section 2068.5 regarding practical experience in education as equivalent curriculum for registered veterinary technicians. The board moved to approve the proposed regulatory text to amend Section 2068.5. Next, we reviewed Agenda Item 5D, recommendations regarding updates to the board's self-inspection checklist. Several questions were raised concerning the checklist content, and it was clarified that the checklist must reflect current law and can be revised as new regulations take effect. Feedback was provided regarding drug security controls, DEA registration, and small animal mobile premises. Additional suggestions will be submitted via email to the appropriate subcommittee prior to the final checklists being posted online. In Agenda Item 7, Justin gave an update on pending regulations. A summary was presented on the 4 phases that a regular rulemaking package must go through. The first is the concept phase, where a program identifies the need for a new regulation or clarifies or revises an existing regulation. The second is the production phase. The full rulemaking package is prepared for initial approval by DCA and the Business Consumer Services and Housing Agency, followed by submission to OAL. The third is the initial filing phase. Upon agency approval, the rulemaking package is submitted to OAL for publication and public comment. And the fourth is the final filing phase. The final package is prepared and submitted for approval by DCA agency and the Department of Finance, and then submitted to OAL for final approval. We currently had 6 regular rulemaking packages currently in progress, each in various stages of the process. The first was the minimum standards for alternate veterinary premises. This is in the initial filing phase. OAL did raise some concerns regarding the proposed language. The subcommittee and stakeholders have provided feedback addressing these concerns, and the board will be reviewing that tomorrow. And then the next 5 packages are listed in order of priority for completion. They're all in the production phase, and that is the drug compounding, medical records, civil penalties for citation, out-of-state registration as equivalent, and license and registration examinations. Anybody have any questions? We will open it up for public comment. Seeing none in the room, moderator, would you please open it up for public comment online?
WebEx is now taking public comment. Please raise your hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take a few seconds to see if we have a request for public comment. Seeing no request, do you wish to continue?
Yes, thank you. Okay, we will move to Agenda Item 5, which is a presentation regarding mobile animal sterilization hospital or MASH-style clinics.
And we have Miss Emma Clifford from Animal Balance, Dr. Dina Allison. She's the medical director from Animal Balance. And instead of Bruce Wagman today, we have Juliana Tetlow from Sene Humane, and I believe that she is on virtually. So moderator, if you don't mind promoting her to panelist.
My apologies, say that name again.
Juliana Tetlow.
Coming right up.
All right, I see her there. Hi, Juliana.
Good morning.
All right. Go ahead. I believe, Emma, I believe you're starting, so take it away.
Actually, Emma, I'll go ahead and start if y'all don't mind. All right.
Go ahead.
Thank you so much. Good morning, committee chair and members. I am Juliana Tetlow here on behalf of San Diego Humane Society. The shelter community, as well as the pet-owning public, have been dealing with a serious shortage of available spay-neuter services for years. Over the course of a few decades, the rise in subsidized spay-neuter access helped drive euthanasia of shelter pets in the U.S. from an estimated 13.5 million in 1973 to 1.5 million in 2019. But when the pandemic triggered lockdowns beginning in March 2020, many veterinary providers and shelters suspended routine spay and neuter surgeries. The aftermath of that decision meant that the crisis rebounded, and in some ways, we are in a worse position now than we have been for 5 decades. At this point, we are fighting a threat to animal welfare and lives of a major proportion throughout California, specifically because of the lack of sufficient sterilization options for both shelters and the public. 60% of California shelters have no veterinarian at all, leading to warehousing and euthanasia related to this shortage. By way of example, Sacramento shelters alone have more than 1,000 animals in foster homes, but at the current rate at which available veterinarians can sterilize the animals, the need will never be met, not in the shelters or for privately owned animals that do not come from shelters when members of the public want to do the right thing and sterilize their animals. As you know, California law prohibits the adoption of cats and dogs unless they have been sterilized, except for counties with less than 100,000 population. And there's no way to get around this important legal prescription, and nor are we suggesting that we get around it, but we do have to figure out a way through it. And the virtually undisputed answer is to utilize veterinarians trained in HQHVSN, or high quality, high volume spay neuter. HQHVSN escalates the speed of sterilization surgeries, increases the number of animals spayed and neutered, and eases the overcrowding and long-term fostering of adoptable animals. It is the most important part of the solutions to address the overpopulation and sterilization crisis we are currently seeing. We all know this, and that was the reason for SB 1233, which will eventually, hopefully, allow for training and production of more qualified veterinarians available for high quality, high volume spay neuter. And SB 1233 programs are not yet established, or while SB 1233 programs are not yet established, there are many California veterinarians who are already trained in high quality, high volume spay neuter. And there are several nonprofits engaged in the provision of HQHVSN services. And as you know, one of them is Animal Balance, whose founder, Emma Clifford, and whose veterinarian, Dr. Dina Allison, you will be hearing from today. So while there is still a definite need for more veterinarians in shelters in California, what is needed even more is the ability to perform HQHVSN in the most efficient way possible, serving the maximum amount of animals in the minimum amount of time, while still maintaining the highest standards, both of medical and surgical care. Groups like Animal Balance stand ready to do this work for shelters and for the public's animals, but they are seriously restricted in how much they can accomplish by California regulations regarding the performance of surgery and the requirements for a registered veterinary premise permit. Ms. Clifford and Dr. Allison will explain the concept, principles, and actual activities of their mobile animal surgical hospital, or MASH, protocols. So I will not go into detail with respect to those particulars, other than a brief description of the process to provide an understanding of the extensive barriers to increasing the volume for efficient and safe spay neuter that are put up by current California law. In short, the MASH clinic is organized, carefully set up, done in a single room where a restricted surgical section in that one room is part of a step-by-step organized processing of animals coming in for their sterilization surgeries and leaving after they have recovered. As Dr. Allison and Ms. Clifford will explain, the MASH concept is transportable, easy to replicate, and results in significantly lower post-operative infection and complication rates than other surgery based on reliable data. The insurmountable legal barriers to reducing overpopulation and euthanasia are found in California Code of Regulations at Chapter 16, Section 2030. These reasonable requirements for brick and mortar veterinary hospitals work well in most such settings, but they make it impossible to comply with the law and perform the best version of HQHVSN to the largest number of animals in an effort to continue to reduce the number of animals euthanized or subjected to long stays in California shelters. Simply put, The current law severely hinders progress on the spay-neuter crisis and will continue to do so unless an exception is made for MASH clinics around the state. In order to provide the most efficient and inclusive spay-neuter clinics with the largest number of animals served, nonprofit groups like Animal Balance need to be able to set up their MASH units in empty public buildings, such as community centers, garages, or gymnasiums. The teams carefully lay out each station for their operations with a keen eye towards protecting the surgical areas, fostering communication amongst the teams, and focusing on animal care. Further, they can be put up safely almost anywhere. Animal Balance operates in several states without restriction and in compliance with those other states' laws regarding the veterinary practice. The problem that we are facing in having these clinics in California are centered around the requirements found in Section 2030, which lists minimum standards for fixed veterinary premises. While the MASH clinics are not permanent fixed veterinary premises, they are also not mobile hospitals, so they do not quite fit into either category, but are presumptively characterized as fixed veterinary premise that needs to have a premise permit in order to carry out surgery. We understand the importance of the premises permit requirement in order to ensure consistency and uniformity, as well as the highest standards for veterinary hospitals treating animals for general or specialty medical reasons. The various stipulations found in Section 2030 range from requirements about facilities operation to specific mandates about the surgery rooms. Those rooms must be separate from the rest of the facility and must be fully enclosed, have doors that comply with the regulations, and include and exclude a number of particulars in the rooms. MASH units do not fit this criteria by virtue of the single room concept, but they are safe, and they are desperately needed to address the backlog of unsterilized animals in California. While we can easily provide detailed examples of all aspects of Section 2030 that either hinder or prevent the operation of the most successful and safe MASH unit operations, I won't belabor the point here and now, but I will confirm that in many areas of California that are in the most need of spay-neuter services, as well as in California's largest cities where the need is also great, HQ HVSN simply cannot be accomplished on the scale needed to try and dig ourselves out of this crisis. And without a legitimized legal pathway for these types of operations, the numbers of animals left behind in shelters and potentially euthanized because they cannot leave will only increase. By making MASH-style HQ HVSN legal and accessible, we can save lives, increase adoptions, and begin to turn around the overpopulation problem once again. San Diego Humane Society, San Francisco SPCA, and the ASPCA have been working with Animal Balance to determine a pathway to change California law solely for the purpose of addressing the spay-neuter crisis. We expect that our coalition will soon grow to include most shelters and pet-related organizations around the state. We are very interested in the board's input and consideration of a solution and path forward to allow for the safe but groundbreaking change in California law. Thank you for your time, and please allow me to introduce Emma Clifford, founder of Animal Balance, to continue this presentation.
Thank you very much. Thank you very much indeed for this opportunity to speak today. I truly appreciate your time. My name is Emma Clifford, and I am the founder and director of Animal Balance. Animal Balance is a registered California nonprofit 501c3 organization. For over 2 decades, Animal Balance has been providing high quality, high volume spay-neuter programs internationally. And since the pandemic, we have utilized our resources to combat shelter euthanasia in the United States by providing sterilization services in several states, including New Mexico, Texas, California, and Nevada. With over 20 years of experience in 12 countries, Animal Balance has performed an incredible 64,000 spay and neuter surgeries. For 20 years, we have provided spay-neuter services to the communities of the Galapagos Islands, and with the local government sterilized 72% of the dogs and 80% of the cats, which has led to extremely successful impacts on native species, such as marine iguanas and blue-footed boobies, allowing all species to thrive. In the United States, Animal Balance delivers a time-tested program called VET-AID, which is focused specifically on increasing the volume of safe and efficient spay-neuter surgeries that can be done in shelters and at specialized clinics, which in turn prevents shelter euthanasia for thousands of animals. This program relies solely on our focused, high-quality, high-volume spay-neuter clinics, which can be replicated by other groups, and we will explain this in detail now during this presentation, and then we'll be really happy to take any questions that anybody has. Animal Balance's focus, and that of other groups like Animal Balance, is to reduce the cat and dog populations throughout the states using our MASH setup. MASH stands for Mobile Animal Sterilization Hospitals. But the mobile in the name is not at all referring to mobile spay-neuter vans. Instead, it refers to Animal Balance's ability to be mobile and to move around the state without the need for traveling spay-neuter vans, which cannot possibly accommodate the volume of sterilizations that Animal Balance can accomplish. Our MASH clinics are by definition temporary, set up to serve a community for 3 days. The layout is built by the Animal Balance veterinary team and locals inside a building loaned for the purpose. The vet team arrives with their MASH clinic equipment. They assess the space, which is typically one large room like a gymnasium or a community center, and they build the clinic inside that space. For example, on Thursday evening, they build the clinic in the room. They run the clinic for 3 days, and then after completing a minimum of 200 surgeries, spays and neuters for cats and dogs, they break down the clinic and the building is returned to its prior use. We have developed and require all involved to follow our extensive SOP, standard operating procedures, that are aimed directly at animal and human safety. The SOPs govern the design and flow of the MASH unit down to the fine details, both to keep the chance of infection and complications at a minimum, and to be sure that all staff and volunteers at any clinic are fully aware of their specific roles. Our teams are comprised of specialized vets and technicians who have been trained in the MASH SOPs, and many of whom have worked with Animal Balance for over a decade. And the proof of the value and effectiveness of our program has been demonstrated with hard data. That is, Animal Balance's post-operative infection rate is 0.26% across all clinics. And our total post-operative complication rate using the MASH clinic model is 0.78%. The MASH unit's focus on animal health is proven by comparison to veterinary surgery data that is available to us. That is, according to the Edinburgh Royal College of Veterinary Medicine, the overall average complication rate for spay and neuter surgeries ranges from an incredible 2.6 to 33%, between a 3-fold and 40-fold greater than our results after 6,000 surgeries. The spay-neuter crisis, as Ms. Tetlow discussed, is real. It is overwhelming in California and cannot really be addressed without opening up the opportunity for a high volume of surgeries and for helping to move shelter animals out to adoption. In addition to the overpopulation crisis that's been going on for decades, in 2020, COVID unfortunately exacerbated the situation as many spay-neuter providers shuttered due to lack of funding or stopped services altogether during this lockdown. This had disastrous consequences, increasing the number of unaltered cats and dogs and increasing surgical backlogs at every shelter, pretty much every shelter. While COVID was not the cause of the current crisis, it only made it worse. In many communities in California, there is nowhere to do this kind of work except in a facility like a gym or a community center. MASH unit sterilization programs help to clear shelter surgery backlogs, allowing for adoptions to take place and animals to leave the shelters as soon as the patient is fully recovered from their surgery. This service reduces shelter stays, which saves money and provides optimum animal welfare. The MASH clinic concept is an invaluable strategy that we are already utilizing in several other states, and will effectively and efficiently reduce shelter stay length and shelter euthanasia, which is a win-win for all Californians and California pets. By turning our attention directly to direct veterinary action by performing spay-neuter clinics in safe, high-volume settings, our veterinary teams can reach far more Californian communities than have ever been reached before. Extending an effective use of MASH clinics is key aspect of the solution to the need for spay and neuter in shelters and local communities. In 2024, approximately 607,000 cats and dogs were sadly euthanized in the United States, with California accounting for the highest state total, with well over 100,000 animals euthanized. We are here today to demonstrate the value of the MASH strategy and to ask for the board's view on permitting this work in California. Currently, California law in Code Regulation 2030 G1 through 5 requires that a surgery unit have walls from the ceiling to the floor and a door, as well as other specific requirements within the suite. Because the MASH unit is set up and done in one large room, like a community center or a gym, the programs cannot possibly be in compliance with the regulations. But to deny them is guaranteed death for thousands of animals. This groundbreaking and life-saving work cannot currently happen in California, painfully limiting the number of sterilizations that can be done at any one time. This leads directly to euthanasia in many cases when animals cannot get out of shelters or because members of the public will or cannot seek sterilization for their animals elsewhere. The undisputed crisis with respect to access to spay and neuter services presents the urgent need for a formal exemption for temporary high-quality, high-volume spay-neuter MASH clinics that do not meet the current surgery suite requirements. The proposed solution of MASH has been proven effective and without danger to animals or to the public, utilizing clear standard operating procedures that maintain the highest standards of veterinary care. As previously acknowledged by the board, a current lack of accessible and affordable spay-neuter services is a significant barrier to access to veterinary care for Californians. We are able to take a good section of that barrier down if MASH clinics can be utilized. The cost for the local California government's savings is undeniable. For example, on average, a city shelter like Los Angeles Animal Services spends $40 per night per animal. So, per Los Angeles Animal Services, the length of stay is 20 days for one animal, and the shelter is required to sterilize the animals prior to adoption. If the animals could be sterilized at LA Animal Services after the impound period, the length of stay could reduce to 3 days. LA Animal Services serves on average 1,500 animals per day. The difference in a 3-day stay versus a 20-day stay works out to just over $1 million. It's huge. You can save so much money. California, the most populated state in the United States, has an opportunity to turn the tide on mass euthanasia and the overpopulation of its cats and dogs. If nonprofit organizations and municipal shelters in California can use the MASH model, they will directly save animals' lives by preventing births and promoting animal health, while at the same time saving substantial government expenses. Thank you for your time. Now, Dr. Dina Allison will speak, and she is the Medical Director for Animal Balance.
Yeah, I think I'm on. So I am Dr. Dina Allison. I am the Medical Director for Animal Balance. I've been with them since my first clinic was in September 2023, and I've been the Medical Director since this past February. I've been involved in high volume, high quality spay neuter though since 1999. And my work experience covers high volume spay neuter, as well as sheltering, private practice, and even some large animal. Done spay neuter work in a huge variety of environments, from those mobile vans to specially built environments like Sacramento SPCA. But you're very lucky in this community to have such a facility, and most facilities cannot, and most communities cannot build a facility such as that. And in my decades of experience, only MASH clinics have come close to matching the volume of surgeries that I was able to perform there on a daily basis without compromising patient safety. So I'd like to provide an overview of how an ideal MASH clinic is set up and runs. Are we able to bring up the map?
Coming right up, just a moment, please.
Thank you.
No, the map.
The map? The map? If not, you can all picture a big rectangle room with 7 stations in it. And so we are in an ideal situation. There you go. We're set up in a circular fashion where everything is in one room. That's going to improve communication across the entire team. Each patient's medical record will reflect their movement through those stations: registration, exam, induction and prep, surgery, recovery, and then release. At the registration desk, we obtain owner information, available health history on that animal. Those are all recorded on the record. Each animal is given a unique number, and that number goes on the patient, their kennel, and their paperwork. At Station 2, a California licensed veterinarian assisted by a technician will weigh the pet, get vitals, perform a pre-surgical examination to ensure that pet is healthy and healthy enough to be anesthetized and is a good surgical candidate. Our animal balance SOPs include strict protocols for age, weight, breed, health grade, and surgical risk assessment. Any patient that does not pass that assessment is going to be sent home with advice and potential options through our partner organizations. We do recognize this is not for every pet. If admitted, that pet will be provided pre-medication and then they'll be kenneled. That kennel bank will stay in the same location all day. The pet will go back to that exact same kennel post-recovery. When it's the patient's turn for surgery, they're going to be moved to Station 3, where they'll be for surgical prep. So induction is managed by a lead registered veterinary technician, and this technician has 2 to 3 RVTs working under them who help with inducing anesthesia under the supervision of the lead veterinarian and prepare the pet for surgery. This is one of those reasons we like to have the induction area in view of the surgical area where the veterinarians are concentrated. Station 4 is our surgical station, and that is managed by the clinic's lead veterinarian. We use California veterinarians, well, depending on the state. Veterinarians experienced in high quality, high volume spay neuter techniques will perform that surgery under the standard and strict high quality, high volume spay neuter protocols. Medical staff in that area wear caps and masks. Veterinarians wear gowns per our SOPs. We confirm that animal's identity. We sterilize the animal, place a tattoo so they have permanent identification that they've been spayed and neutered or sterilized, and ear tips are performed if requested by the organization. Station 5 is our first stage recovery, and ideally, again, within sight and hearing distance of that surgical station, so the veterinarians engage in real time with the lead recovery RVT to ensure all patients are doing well as they return to consciousness. We have 4 to 6 experienced RVTs and volunteers that monitor the animal's recovery. They support that transition to consciousness. They remove the endotracheal tubes, monitor temperatures, provide heat support as needed, ensure the animals are breathing adequately, heart rates are adequate. They also vaccinate and microchip in this area if it's indicated. After being medically cleared to their sternal, breathing on their own, temperatures are appropriate, they will be cleared for second stage recovery where they're returned to their kennels. Those kennels have been cleaned while they're in surgery. And the kennels are continued to be monitored by volunteers. They're monitoring for post-op behavior such as lethargy, weakness, pale gums, any bleeding in the kennels, brought immediately to the attention of a veterinarian. 2 hours post-op, a discharge exam is performed by a veterinarian or an RVT. Paperwork then moves to the discharge desk. Owners are called. Each patient then goes home with post-surgical medications, an e-collar, a document with aftercare instructions, which the discharge team verbally explains, answers any questions they may have. We also provide links to medical consults so people go home with additional information, a video that reviews all of those aftercare instructions. They also have access to a 24/7 post-op call line in case they have any concerns. In addition, we make arrangements ahead of time with local emergency or private practices because we are a temporary structure, and we want to make sure those clients and patients are supported after we've left. So we arrange a payment system and a reporting system so that we hear about any post-op complications. It's important to us to provide this aftercare for post-op complications so we can continue to make data-driven improvements in our protocols. In my personal experience, MASH clinics have provided more animals sterilization than any of the mobile spay neuter vans, private practice, or traditional shelter environments that I've worked in, and thereby they're going to significantly impact that spay neuter access problem. I just described a situation where everything's in one space, and that does allow the veterinarians to be in visual and audio range, both of induction and that first stage recovery, so it can act quickly if there is a medical issue. There's a lot of moving parts being overseen by those veterinarians. And the single room, I feel, gives us the best level of supervision. In California, when we have to separate that surgical suite off into another room, and in my experience, that has been closets, where we go into a closet and the door gets shut. This reduces communication, oversight, and safety, both for the pets, the staff, and the veterinarians who are stuck in an uncooled closet in the summer. We do have strict protocols to make it safe to do surgery outside of that space. We pay special attention to that maintenance of aseptic technique. We visually isolate the suite for participating staff. So we place down some duct tape around that surgical suite. We require 10 feet minimum of space between the tape and the recovery stations and prep stations where there's patient movement, animal movement, hair. In addition, from that tape, there's another 3 feet to the closest surgical table edge. We require limiting staff. We don't have any exterior door access in this area, no open windows, no fans in the area other than things that blow directly onto the vets to try and keep them cool. As I said, only necessary team members are allowed in the suite. That'd be like surgical assistant who's doing anesthesia monitoring, patient transport would be temporary, prep techs temporary, and then the veterinarians. Cross traffic is definitely limited. Anyone in that surgical suite area has to wear a cap and mask. The surgeons wear their cap and their gown for each procedure. Everyone gets their sterile pack, individual pack. As I said, there's no use of vacuums or sweeping in the area when patients are present, no fans. And I just want to thank you for your time today. I'm happy to answer any questions about the nuts and bolts of how it works, if you have them. Otherwise, I'm going to pass back to Emma and just let you know we have access to our full range of soaps available to you if anybody wants access to those.
I have lots of questions.
Do you have
A video? Okay, good, video.
Okay.
One moment for the video, please.
It's looking pretty good. They make this big.
Would you like me to begin playing?
Yes, please.
Audio.
Moderator, we do not have audio in the room right now.
Hi, I'm Dr. Compton. I'm here with Animal Balance. This is my 5th Animal Balance clinic that I've done. We do MASH style clinics where we provide all of the resources for spay neuter to different shelters or areas that are in need. A lot of times these clinics are in areas where there's a lot of families that don't have access to veterinary care, and we provide these clinics at a low cost that is affordable to families. So we're able to provide spay neuter services for these families that they otherwise wouldn't have the access to.
Sterilization clinic with Animal Balance. What's great about MASH sterilization clinics is we're able to go into the communities that really need spay neuter services the most, and we can provide high volume, high quality spay neuter at a lower free cost. The other cool thing about MASH sterilization clinics is that we're able to bring in the experts who do this very well into the communities together in order to provide a really cool experience for us, the animals, and the community.
Okay, do we have questions? Dr. Waterhouse?
Hi, thank you for your presentation. I was hoping we'd actually see video of the whole process, like start to finish, but, so yes, I have lots of questions.
We can absolutely send you a video. We
What?
have those videos. If you
You
would
have
like us
video
to
of
send
the
you some
whole-
more videos, we can certainly do that.
Yeah.
Yes.
If you don't mind Emma emailing those to me, I can send it out to the members.
Okay, lovely. Thank you.
And so I have a lot of technical questions, so I'll speak to you. So what anesthesia do you use?
Typically, we're using a combination of tilazol, so the toluidamine zolazepam, combined with either nalbuphine and or corbigesic, and dexmedetomidine. So we're using a compounded IV, typically administration.
Okay, and so, but you're using Torb
We are using either butorphanol or nalbuphine,
or, I'm sorry, what was the second one?
or nalbuphine.
Okay. And who induces anesthesia?
Induction is done by the lead RBT.
Are there veterinary assistants involved in inducing anesthesia?
There typically are not veterinary assistants involved in inducing anesthesia. It is almost always the lead RBT and another RBT who is doing the prep. So we staff that entire area only with RBTs.
Is that almost, or is it never that a,
There may
Yay.
be an assistant holding and restraining the animal, but there is no injection done by anyone but a licensed RVT.
okay, okay. Are they intubated?
They are all intubated.
Are they put on gas and oxygen?
I want to step back one time. If for male cats, if the veterinarians who are present at that facility have concerns about intubation of male cats and procedures that take less than 10 minutes, we will allow them to make that call that they do not want those cats intubated.
Okay,
But every spay and every dog, they are intubated,
and put on gas and.
put on oxygen,
Okay.
and then we use isoflurane as needed to support.
Okay, and what instruments did you put in a pack?
That can vary a little bit by our partner groups, but ideally there will be 2 Carmelts, 2 Kellys, 2 mosquitoes, a spay hook, thumb forceps and needle drivers, as well as Metzenbaum scissors, a drape in each pack.
And scalpel handle?
There are not scalpel handles in each pack because we found that veterinarians were not using them and taking up space.
Okay, and is each pack sterilized?
Yes.
And how many packs do you have?
It depends again on the individuals. We've worked with as few as 20 and we've worked with as many as over 60.
And so if you have more animals than you have packs, then
They are being processed, cleaned by volunteers. They're being cleaned and re-sterilized, repacked and re-sterilized.
Okay. And how are you determining your complication rate? Just by what's recorded on the phone?
Yes, so reporting on the phone. So anything, I developed a reporting system. So we have intra-op reporting as well as post-op reporting. And we grade that on 5 stages. So anything that just requires communication is stage 1. Anything that requires drug intervention is stage 2. Stage 3 is anything that you need to go back in on a procedure. So say we have a hemoabdomen, we have to go back in. Or that would be stage 3. Stage 4 needs to be referred to an emergency hospital for additional support. And stage 5 is if we unfortunately lose a patient.
Okay, so though you're looking at that while they're still on the property?
On the property and then follow up. So any callbacks, any emails that we get.
Okay. I just don't know if you know your true complication rate. That from my personal experience in my own community,
Mhm.
the highest complication rate we see is from the high volume spay neuter hospital by far. Much higher than our own rate or much higher from any other veterinary hospital. So just that's my personal experience.
Yeah, I think that's one of the reasons we've been trying to really reach out and get to the local clinics. So reaching out and sending our clinic coordinators in ahead of time to communicate with the local clinics and try and develop those relationships so that they will get back to us and let us know if it came from our clinic.
Yeah. And how many, so are you associated with any specific shelter, any specific?
No.
So you just, okay. So my question is, how many of these animals that have been spayed and neutered at some point in their life that are still sitting in shelters waiting for an adopter? I mean,
Oh, after
so
they-
we spay and neuter all these animals. Are they going to get somebody to adopt them anyway?
Okay.
I can explain from LA Animal Services, the most recent experience that we've had. We were there when we did 1,200 surgeries over 6 months, I believe, 7 months. And the way that they work, and I think this is a very good way actually, is they work very closely with the operations director on length of stay with the what's called as the hope list, and this is a list of rescues, and the rescues are called constantly once they have the animals through the system, and they can be moved out to those rescues. So sometimes we're actually serving animals that are in rescues that still need to be spayed and neutered, but they've been allowed to be released by LA Animal Services. So sometimes those animals are coming in from rescues, but they're actually just been released from LA Animal Services. Does that help answer your question?
Not really. No,
There's-
it's just,
How long do they stay fixed at the shelter is going to
I
be
know.
per shelter, isn't it, and per community. So it's hard to give you a data on that. But by working with those rescues, we can reduce that length of stay.
if there's somebody out there to
If
adopt
there's
them.
someone else out there doing it, exactly.
Yeah.
So I saw Juliana came on camera and unmuted. I'm assuming that means Juliana might be able to help answer the question.
Yeah, so there's not going to be, a clear answer to that question unless, we studied the lengths of stay at every shelter. But I just want to note, from San Diego Humane's perspective, we are, truly blessed to have, more veterinarians on staff probably than almost any other shelter in the state except for LA. The most recent report we have from our staff as of Monday, 16% of our animals in care were awaiting spay neuter. That's 288 animals that are awaiting spay neuter. And I think that, there's no guarantee that once they are altered, that they immediately, have a pathway to adoption, but certainly that many animals awaiting spay neuter because of capacity is a real challenge. And that's just our shelter, of course.
So 84% have already been spayed and neutered?
Yes, doing the math the other way.
And they're awaiting adoption?
For varying reasons, there are some that are in behavior modification
Okay.
programs. They're not all available for adoption. If they've been altered, that, obviously makes that adoption pathway much faster once any other program that they might be a part of within our shelter has been completed.
Okay, that's my question.
Thank you very much. I'm the public member here, so excuse my probably ignorant questions, but but I'm very interested in your process, and I look forward to seeing the full video. I just wanted to ask, in a gymnasium situation, do you have one set of 6 stations or multiple sets of 6 stations?
One set of 6.
One set of 6 stations, okay. And then in some of the stuff I read, and I think you said it today, you can potentially in a very high volume setup with whoever the partners are, do 200 a day. So, and 200, over 3 days, I'm sorry. Yeah,
Yeah,
right. Okay,
if the animals show up,
yes,
we get the 200 done
okay, over the 3-day
over the
period.
3 days. Yep.
And
And we
then-
have gone beyond that.
Okay,
So typically our partners will book 80 to 85 animals a day. And if they all show up, they would get done. It's the no-show rate that I think affects our numbers.
and are your partners, so you're working with some shelters who they don't have a vet in-house, so they would bring all the animals they need to be neutered or spayed in for that? And then are you also open and publicized to owners, individual owners? Or do the partners like the SPCA publicize the event and individual owners come too? I just want
Partners choose how that works. So here in Sacramento, I worked with one that was, we've worked with Front Street
yeah.
Shelter a couple of times. And several of those times to work on their animals. And the most recent one that I worked with them, they had a grant from the city, and it could only be animals that were owned. And so even when those owners failed to show,
Mhm.
that was the number we got to.
And as an individual owner, if I'm coming in with my 2 rescue cats or whatever it is, there's an entry point where I go and I saw the registration table and the intake and all the rest. Then I leave physically
Mhm.
and I'm outside that room and then come back at the time the animal's ready to
The
be
only time,
discharged.
yes, the only
Correct.
time I actually have owners come in is say we have a very stressed dog
Yeah.
that is doing better with the owner. We might have the owner stick with them through the exam period and the pre-medication period, and then help us get the animal into the kennel so that they have a safe entry into the system.
And then are there any requirements or limitations on the age or the size? In these high volumes, I'm thinking of complications and situations like that with an older dog or a large breed dog or something like that. Do you have limitations?
Absolutely. That is part of our SOP. So we try
Okay.
not to do dogs over 8 years of age. We don't like to do dogs with heart murmurs. I don't like to do what I call the smushy face dogs that you can hear coming. So
Mhm.
if they're breathing so loud and have elongated soft palates and stenotic nares, they may not be a good candidate for the situation. We
Right.
don't want to do dogs that are going to be we're doing these on tables that are used, event tables, plastic tables. I don't want a dog over 100 pounds
Yeah.
on that table, putting the dog or the staff at risk. So absolutely, we have in our.
So you advertise that in advance so people don't come if they, right.
We do. And sometimes the partners who are booking the appointments don't do a great job on that. And that's why if they don't pass our SOPs, then we go out and we have a chat with them.
Yeah. Okay.
Have a chat with the owner, take the time to have the veterinarian go speak with the owner and about what the risk is, why we don't want to do that, and work with our partner groups to get them a safe option for that pet.
And then lastly, if you were in California doing these in a rural area or whatever, how do you recruit vets to participate?
Fly them in.
And they're all
Something-
licensed California vets?
Well, and I've come from San Diego. So we have San Diego Humane has sent veterinarians up to Clear Lake. Clear Lake's pretty remote area, but and the local vet who's there has gone and met with the local practices and tried to build those relationships that we're going to be coming in.
Same with RVTs, I take it.
RVTs, yeah, but we do not have people come in if they're not licensed. So part of the admission process in the filtering is to interview with Emma and I think it's Isa.
Yeah.
Yeah. And they are reviewing the licensure, checking to make sure the licenses are valid and up to date. They also then might call me, so we have a new veterinarian who'd like to come work with us. And so the clinic coordinator would call me and say, have you heard of this person? And I'll reach out and say, hey, I don't know their reputation, but let's get to know them, because I want to make sure these are folks who are good at high volume, high quality spay neuter. We don't want people coming in and learning in this situation. This is not a learning situation. This is
Right, and that's what I've always understood. The training for high volume spay neuter is, if you're a regular vet at your regular office, and I know Dr. Miller has talked about the potential training that UC Davis can do and things like that. There is a sort of fundamentals to doing the high volume safely, thoroughly, and everything else. Okay,
Yeah.
so you have multiple vets working in this 6-station area, only one surgical.
We typically have 3 veterinarians on site,
Okay.
3 to 4 veterinarians on site for a clinic. So we try to have one vet who's available for exams, anything that comes up. Particularly in California, when we have to have the surgical suite off, we try to have one veterinarian who's available at all times for exams, and then 2 to 3 veterinarians are doing surgery.
Okay, thank you very much.
Go ahead, Dr. Solcito.
Hi, good morning. I'm Maria Solacito. I worked the shelter for 15 years. So I totally get what MASH services are all about, and I think it's badly needed. I have seen an increase in folks seeking services, at the shelters, and the shelters could barely perform spay and neuters on the animals being relinquished or being impounded. And then on top of that, you have communities asking for services, right? And I would say I've been trained at Humane Alliance before I became ASPCA. And so I would say, for the board, it's like art in motion, I would say, the way that it is being done, the high quality, high volume. But I would also say that it really is highly dependent on the protocols being set, the veterinarians being trained, and really having good oversight, and also RVTs. We have a huge number of RVTs that are very much well-trained and has that clinical eye that really becomes like a big support for our veterinarians, which expands the ability to provide the services. And on top of that, volunteers. I would say these organizations have the ability to really attract volunteers that would provide free services and also are willing to be trained and abide by the standards. So I would say that is a great, opportunity, if that is something that California will be able to provide the necessary support. The only thing that is not a concern, but the only thing that I would want to mention is with 3 veterinarians, do you have a pool of other veterinarians? Because I feel like the need and just providing the VCPR, right? And providing the services for all of those animals. I'm just afraid that we're eventually going to be going down the route of burnouts. And so what are you guys doing, to handle that?
Okay, that's a wonderful question about the capacity for veterinarians now and in the future. You're absolutely right. This is hard work, and the veterinarians that do high volume spay neuter tend to have 10 to 15 years before they unfortunately get arthritis and other things. Sorry, but that's what happens, isn't it? And so you're right. The pool of veterinarians needs to be expanded. Actually, we have 97 high quality, high volume spay neuter vets on our list. And that's because we've been working in California now for 2 years. And our community is actually very tight. We're all 0.6 degrees from each other. And we don't always have to advertise for veterinarians or technicians. It's through word of mouth at the clinics. When people are in the clinics and they're listening to their fellow colleagues talk about what they did last weekend, they want to be part of it. I was speaking to a veterinarian last week and I said, how on earth did you find out about us? And she's actually one of your friends. And she said she knew Dr. Dina, and then she also knew a technician that she'd worked with. And they came back the week before and they were just bubbling over with how excited they were about what they'd learned, and they were enthusiastic, and there was a solution-based strategy that exists, and we should get involved. And the next thing you know, then I've got more veterinarians and technicians applying. So it's very much word of mouth. It's very much like a ripple effect that's happening right now. And it's been happening in the last couple of years. You may have noticed that more veterinarians are learning high volume, high quality spay neuter. The gap is, the tricky part is exactly what you said. If the students are coming out of school, they are not able to do 25, 30 surgeries a day. So how do we bring that population into this work? And that's what we're talking with UC Davis about right now, actually. How do we get these grads who are very excited, very enthusiastic, they know it, but they just don't have the experience to do 25, 30 a day. So that's what we're going to start addressing now, looking into the future. How do we build up kind of like the army, if you like, of high volume spay neuter vets and techs to be able to do this work once the pathway is open to us to be able to do it? We have an opportunity here to do it, and there is excitement within our industry, wouldn't you say so, to do high quality, high volume spay neuter MASH work? It's starting to build up.
The other thing I would say is I've definitely, I got myself licensed in some other states, and I'm going to other states. And when we do the MASH in the other states, I'm talking up getting licensed in California and like the path to licensure here. So trying to bring vets here. so that it's just, I don't want us exiting. I don't want the California vets leaving, going someplace else. So when I say I got licensed other places, it wasn't so that I can leave California. I want to bring other people here and show them that there's a path to licensure here and work to be done here. I did have the opportunity to do some training when I worked at Front Street for new students, and there is a curve. It's a, you know, it's a slow curve at the beginning, and then you take off. And I think Em and I have been discussing how can we start integrating some of the younger vets into the setup day or covering lunches where they're the exam vet, and then they can cover lunch with a vet sitting that, you know, a mentor who's right there, and knowing that the pace is going to slow down because people are at lunch and they're going to have some time to do that and get some feedback. Because I mean, that's how a lot of us started. Like when I started, there wasn't the Humane Alliance training. I started in kind of a MASH style thing in Placer County, and just another vet coming over and saying, hey, why are you doing it that way? This would be easier. This would be easier. Working on your tissue handling, because I think that's the problem the younger vets have. And I think that's why at some of the high quality places, if you don't have the more experienced vets, you may have a higher complication rate, is because the tissue handling is not there yet. I know my own complication rate has significantly decreased over the years because of the tissue handling experience. So I think that's something we need to help the younger vets with.
And the other thing, I also write grants to bring in vets from out of state. Super high volume spay neuter vets, the ones that we've worked with in other states. We target them and we write grants for the funds for them to be able to come and become licensed in California and work with us. So there's that added aspect as well. Thank you.
Hi, I'm Dr. Jenny Gedkin. Thank you guys so much for the presentation and doing what you're doing. I do want to mention way back in the day when I was in vet school in Illinois, we had access to one spay and one neuter in school, period. And my neuter was a cat neuter. And knowing that I needed more experience back in the summers of 2001, 2, and 3, there was a service called Remote Animal Medical Service, which is now RAVS, Remote Animal Veterinary Services, with Susan Monger, who is amazing. I'm sure you're familiar with her. And what she did is we, all the way from the cornfields of Illinois, spent our summers out here for the first time ever. I stepped foot in California, in Northern California, in the reservations, as well as I think I did one in Washington, where we spent weeks here doing what is now considered a MASH style clinic. And it was not technically high volume because we were students, right? So exact same layout before it was known as MASH, but we had licensed veterinarians, we had the stations, we had Dr. Monger, who is fantastic. I think she's probably one of the forerunners in MASH. Right? I could still hear her at the anesthesia. She would be the one inducing anesthesia and everything. I got my experience in surgery, again, not high volume, but surgery in an abdomen with veterinarians with me. And to say that that was by far the most practical experience I got in 4 years of veterinary school is an understatement. So I know who you service is a little different, right? You are more focused on removing a barrier to adoption, much needed. And I thank you for that. I do have experience in these clinics from a student standpoint. And again, the only difference is I would not call it high volume technique, right? My incision was huge and everything, but I will say while we're talking about buzzwords such as access to care, getting more students familiar so that with even not just high volume techniques, but just techniques. So on day one, they are more serviceable to the public. This is a huge, huge thing to be talking about. So I know up here, I really appreciate my 3 summers of MASH experience. And I know if we can make sure that we are not in direct violation of any black and white standards, you will have 98 California veterinarians licensed to be helping you with this mission. So thank you for what you're doing.
Dr. Sullivan?
Yes, and thank you for the presentation. And I'm really looking forward to seeing the video that you have of the whole process. I think that's going to be key. I got the impression when you were talking about doing the MASH program in California, you were using a second room as the surgical area. Is that correct?
Yeah, so we have not been able to do classic MASH in California because of the way the laws are.
And what is the volume that you are doing in that situation?
We're still getting it done. I just feel the communication is tough. So different facilities we've been in, the animals are off in, we might do it like at LA, some of the animals may be in the room and the kennels in the room and then off in other spaces. Recovery may be in a hallway. So the communication when there's a problem takes longer.
Okay.
And I think that's been the biggest issue. And the animals are not in the center. So we have volunteers who are walking through and then have to go find a veterinarian to get help.
Okay, and then on your diagram, it looks like you have 2 tables in the surgery area.
Ideally, there's 2 to 3 tables in the surgery area.
So you do have animals being brought in while another animal is under surgery?
Yes.
Okay.
So there is that level of movement, yeah.
Okay, so from your presentation, I'm seeing that the obstacle, and let me know if it's not, if there are other obstacles, is the definition of the surgical suite.
Yes, I would say that is where the floor to ceiling and door has been the biggest issue. We used a building in Santa Cruz where they have permanently sealed a window so that it can't open.
Okay.
We have to close the doors. Again, there's a communication issue.
Well,
That part of the circle is stuck in the room.
This really helps because I think it will help us focus on what we do need to address because I mean, that is our job, is to make sure that that we're complying with the science of the surgery, not just the data that's out there. I saw one of your data points was the veterinary school at Davis, and I'm sure that they were using students for that data. So that's skewed a little bit.
Well, and there's not a whole lot of published data out there for surgical infection rates. And, my understanding when we're really trying to think of what the purpose of that surgical suite is to reduce the infection rate.
Right.
And so that's why I've been tracking that in particular. Since I took over, I've had them pull that out as part of our surgical complications so that we can track it a little better. I'm also tracking by veterinarian so we can catch if we have a veterinarian whose technique needs some oversight,
Yes.
so that I can have that feedback with that veterinarian.
Okay.
And I'm not afraid to do that.
Yeah.
Get on the phone and have a conversation and do some mentoring.
All right. Thank you very much.
Christy?
Thank you, Dr. Sullivan, because that's kind of where I was going, is that we need to focus on what we need to do on our committee. And so I appreciate you being here and hearing all of this. And though I agree, I understand why Dr. Waterhouse asked those questions and all the SOAP, just for everybody's information, it is, if you look at our materials, you can click into our materials and their SOPs are all in the materials that we have. So you can read all of their SOPs and go through it, and you can read through everything that they have. So it is on their website. And I think that that's super important because it is not, I don't think that what we're here right now is to determine all of what they do for pre-anesthetics. And that I don't think is the biggest concern. I think right now we need to get to our job right now, and that's the surgery suite, because that's what we need to define and that's what we need to look at as a committee, because that's the piece. That's what they cannot do right now as a MASH unit. Everything else they can do. It's the surgery suite. So how as a committee do we look at that? And am I misunderstanding that? Jessica? I'm putting you on the spot.
Well, the direction from the board was to learn more about the setting and learn what potential hindrances are to them providing the services that they are providing. So they haven't been very specific on go and make these changes. Is here, learn more about it, understand what is what's hindering them from doing what they're doing, and then make recommendations.
Yeah, I wasn't saying that so much. I was saying, but what's hindering them, finding out what's hindering them, and what's hindering them is, as Dr. Sullivan just alluded to, is the surgery suite. Dr. Nunez, did you have something?
First of all, I apologize for being late. It never rains in California, but when it does, it delays the jets. And I'm almost embarrassed to ask my question because of what Christy just said. Because I do have questions on standard operating procedures and so forth. And so would you indulge me? And I believe I heard most of your presentation on the podcast. But if you already answered the questions that I'm asking, just say, we already answered that in the interest of time. Is there a pre-anesthetic evaluation done by a veterinarian before they go for their anesthesia?
Absolutely, yes. So station 2 is the exam period, and the veterinarian who does the exam makes an assessment whether that patient is, I really aim for anesthetic risk 1 to 2. So if there's something that's pushing a patient kind of in anesthetic risk level 3 or greater, I'm going to have a conversation with the owner. And that includes, like, even if they are like a Doberman and who hasn't had testing, I'm going to go have a conversation with them that we have a high risk waiver that they sign. If they really want the animal to stay, then we do a buccal mucosal bleeding test, trying to really assess whether this patient is safe to move forward.
And also, thank you for the work that you're doing. Don't interpret our questions as disapproval of what you're doing, because we're the regulators and that's just what we have to do.
Absolutely.
You said that there was an anesthetic protocol of tilazol and butorphanol. Are there other anesthetic protocols available or just one size fits all?
Typically, we are doing a one size fits all, and that would be the tilazol compounded with either butorphanol or nalbuphine, and then dexmedetomidine. So that three-part combination. We also have, for additional pain control, we have additional buprenorphine available for that. We do local blocks with lidocaine for pain control. So, and then they do come with a non-steroidal anti-inflammatory. So we are saying that it is one size fits all because we are accepting patients into a MASH situation that are suitable for that protocol. So if this is a patient that needs a cardiac protocol, where you might do the, midazolam, propofol, et cetera, sevoflurane, then I'm going to say that is not a patient for a MASH clinic.
Yeah. And you said that there's no scalpel holder in the pack?
There is not,
just
because
hold
we
the
have,
blade?
and a lot of high volume spay neuter places that we work, you don't want it there. It's an extra instrument to dig through. It's an
So
extra
they just hold
instrument
the
to
blade
dig
with their
through.
hands?
Their
So, yeah,
incision is like this big, like
So
it's.
my typical incision for a cat spay is about 8 to 9 millimeters, just large enough to get the spay hook that I'm provided in. And so that would be the main variance, is actually the size of the spay hook.
And then
On a dog, it's going to range from 1 centimeter to maybe 2.5 centimeters. And that would be a large incision.
don't laugh at me.
No, I'm not laughing. I was saying the largest incision I've made in the last year was to accommodate, I had my first teratoma on an ovary, and it was just to get out an ovary this big. That was the largest incision I've made this year.
And then recourse for consumer complaints. Have you had any consumer complaints? Any action taken to the boards?
I'm not aware of any action to the board. We really do try, anytime something comes up, we try and have that communication right away.
If there was a consumer complaint, it would go towards the veterinarian that performed the surgery?
Yes. All veterinarians who work with us are informed that is their personal liability for their surgery.
Okay. And then getting specifically to Christy's concern about the surgical wall not being in place, one of the reasons for the regulations is to ensure sterility of the
Correct.
surgical suite. So do you have any information on infection rates, postoperative infection rates?
We did cover that. Our typical infection rates are less than, I think less than 0.3%.
Yeah, that's 0.3.
And across all states,
say
we kind of pull out states individually, and I think the highest we've had is 0.4%,
Okay.
0.45 actually.
Post-op, yeah, post-op comp rate is 0.78.
Total
Complication rate?
complications.
Total complication rate is 0.78.
Do you have infection rates?
Infection rate is 0.26.
Okay,
Thank you.
thank you.
And then we do give that information to each, if a veterinarian calls us, we can pull out their data and let them know what their complication rate is. So I have it flagged for anybody who's at 1.5% or above for overall complication rate, that I should be informed. And an infection rate at any clinic coming back at greater than 0.5%, I need to be informed.
I used to do high volume spay and neuter clinics when I was much younger, and it is very hard on the back standing that long, I must say. So keep up the good work.
I just have a follow-up question with regards to the complications. So what is the protocol once there's reports of like infections, complications?
So our post-op line is manned by RVTs. They may or may not be licensed in California. The RVTs who monitor the post-op line, they are licensed in a state. Typically, I think we have Texas, Colorado, California are our post-op, and New Mexico are our post-op RVTs. So we don't require the person monitoring that 24/7 line to be licensed in California. But then they will, if it's just questions that need to be answered, if the client has concerns, like, does this look concerning? They will actually forward the pictures to myself, like, so that we do, since we've already established our veterinary client-patient relationship, I can now, with California law, I can do some follow-up with telemedicine. And so I look at that. And then if I think it cannot be assessed appropriately by photo, we will refer them in. So if it looks to me like there could be anything going on that needs to be seen in person by a veterinarian, we refer them in for aftercare. So say it's bruising, I might say, hey, let's see another picture of that in 12 hours. Can you have the client draw a line around that bruising? How is the patient eating well? So I'll ask those questions. The staff will give me those answers back. They'll send a picture in 12 hours. The bruising hasn't progressed. Patient's still eating. I might say, let's continue to monitor. But if there's anything concerning, patient seems to not be eating, lethargic, we're going to refer them in for follow-up. And ideally, they get someplace that has ultrasounds so that they can assess for anything. Yes.
Another follow-up question. Is there any scheduled like quality control, in the process? Because, when you've been doing things repeatedly, over and over in such high volume, complacency is an easy thing to fall into. Is there regular, what you call this quality control, or do you have a third eye that, does, oversight in the way that things are getting done?
So I'm trying to use the the data to flag for that. And then each veterinarian is responsible kind of for checking the sterility of their packs, that the packs are complete. So if we start seeing that we're missing instruments in the pack, because it can happen, that pack will get put aside, and then we'll alert someone to go have a conversation with the pack team, like, hey, are you guys tired? Do you need a break? We've been noticing some instruments are missing, so we're trying to give immediate feedback on that as far as that. But that responsibility, just like at any practice, is going to fall with the veterinarians, because that's the ultimate responsibility for that animal safety is with those veterinarians who are on the ground. And then we do weekly meetings with management. I think that's Tuesdays. And then Wednesdays, whole staff, where we get together and we discuss how any clinics that were run that week went, any feedback that we have. So that we have weekly meetings to follow up on feedback from those meetings.
And I can also let you know that every team is a different makeup of pupils.
Mm-hmm.
So every time we have a clinic date, people are applying, vets and techs are applying for that particular date. So not every team is going to be the same. So prior to every single clinic, every tech and every veterinarian and every assistant and volunteer has to watch the video related to section of the MASH clinic that they will be working in. So they have to review this information every single time because we're getting better and better and better at doing this. So we may have made some differences from the last time that they teched with us. So they have to go through the training each time. And that's really important to us that they do that. The week prior to the clinic, they've been reorientated again. And then when they arrive, they have another physical orientation in place and are able to ask questions to the medical director or the manager of the clinic. So we're very precise on that. Thank you for asking it.
We also do at each day, at the end of the day, we go through the whole day and we start with like, hey, how did check-in go today? Does anybody have any feedback on how check-in was handled today? How did exams go today? Did we have any feedback on how that went? Anything we want to change for tomorrow? Because each team, it is, right? We're bringing a new team of people together at each location. And so you have to build that team that so that you're a high functioning team as quickly as possible. So I'm not going to lie, the first days are rougher than the rest. Usually by day 2, the teams are high functioning. We work out those communication issues because we encourage that communication all day long. And then we have a big summary each day and then a check-in each morning. Check-in each morning, communication throughout the day, summary at night.
Dr. Waterhouse? You want to go to Dr. Gedkin first?
Dr. Gedkin
Okay.
first, I think.
Okay, going back to Christie's comment, I'm going to revisit 2030 right now. The separate surgical suite, right now, if I put on my inspector glasses, technically, the whole gymnasium, I would consider your surgery suite now. So technically right now, at one of these MASH style clinics, technically, not only do we not have a room separate, but we have storage in the surgery room. We have surgery room shall not contain a functional sink. They might be in violation of that, right? The doors into the surgery room must be able to fully close, must be non-porous. The surgery room must have equipment for viewing radiographs right there. There's another one about open shelving. So right there, if I were to walk in and inspect this clinic, it's not technically, you don't have 4 walls. Is these 4 walls of the gymnasium, you are considering your surgery suite, and your surgery suite has all of these. So as an inspector here, I'm not even inspecting for sterile technique, right there, you're in violation of these structural things, right? So I'm not even looking at their SOPs or anything like that. That is the issue now, is that the surgical suite is considered the whole gymnasium. It doesn't matter, as I'm the inspector how they separate and everything. The black and white as it stands right now is I would be writing them up for that, plus all of these things that domino. So right there is just a black and white issue. And they're not even talking about exemption for the quality of medicine that they are delivering, right? They're not saying, because we do this, we don't want to have sterile technique. We don't want to give pain meds. That isn't the issue. Now, I do want to point out in 2030 G1B, there is a leeway. The board may exempt a veterinary premises, which is currently registered with the board, but does not have a separate aseptic surgery room, where it determines it would be a hardship for the veterinary premises to comply with the provisions of this subdivision. And it is when a hardship exists, if there's zoning limitations, if the premises constitutes a historical building. So I just do want to point out whether compliance with this requirement would compel the veterinary practice to relocate to a new location. So I just do want to point out right now in 2030, I believe it's G1B, that there is already a little bit of a leeway exemption, meaning back in 2012, if I did inspect, and I did actually inspect a veterinary premises that did not have floor to ceiling, they could actually petition to the board or enforcement. We are requesting an exemption because we're a historical building, something like that. So I do just want to point out that there is already a little bit of language.
I don't think that even qualifies for them.
No. I'm just pointing out that there is already a pathway for exemption for a surgical suite. So this right now isn't just floor to ceiling right now. If they were to be inspected, they would, yes, be written up for a few things. So just pointing out what in black and white is a barrier now to the structural limitations according to the Practice Act.
Dr. Waterhouse?
Yes. So how many sites in California have you actually done your MASH?
Well, because we cannot do true MASH in California, we haven't done true MASH.
So how many sites in
But we-
California have you done your procedures?
In total, gosh, we've been doing it for 2 years now, and we're doing 5 a month.
How many sites?
So I'm going to guesstimate that we've probably hit 250.
You think you've done two? I don't
About
know.
200. About 200. I can get you the exact number when I get back, but about
200 times?
Yeah, there's about.
How many, but how,
Back to some of the same sites.
right, so how many sites?
So how many individual sites? It's probably just over 100 at this point that we're engaged or have engaged. What happens is our partners are all different. Some of them come to us with the funding. Some of them have to find out what we're doing, and then they go off and get the funding. So then they come back 6 months later. Some of them want to do one clinic, see what it's all about, and then they'll ask for another 6 clinics right away. So it does depend, and we're constantly talking to partners. And there's going to be humane societies, SPCAs, animal controls, or friends of one of those organizations. So they're
Okay,
all
so
different.
just real quick, do you send home paid meds for the owner to give at home?
Yes, we do.
Okay.
Yes. They go home with pain meds. And then if the veterinarian has any concerns at all, like I said, there's additional buprenorphine to give. And we do have the 1.8 mg per mil to give to cats for longer acting.
Okay, we do need to take a break before 11:30. So let's take a 15-minute break, return at approximately 15 minutes, return at 11:45, and then we'll resume questions after that. Thank you.
Thank you.
Okay, we can go ahead and resume with any questions left from the committee. Anybody have any further questions? Okay, Dr. Nunez?
My question was on logistics, on what we would need to do to allow these MASH type clinics to operate. Would we have to make exemptions to what's currently in the Practice Act? Or would we have to change regulations in establishing a new practice type? Like we have a practice type for small animal fixed, practice type for mobile. Could we, can we, would we create a new practice type for these MASH type situations?
Go ahead. And that's a great question because we have to back it up one step further on how are these MASH style clinics even going to obtain a veterinary premises permit to put them on the radar. So even when I said, oh, if we inspected and we came in, I don't know how you guys, how we're structured now would receive a premises permit unless it would, no, yeah.
And would it be legislative changes or regulatory changes?
So I don't want to get too bogged down in solutions at this point because we want to hear what the concerns are, share that feedback with the board, and then ask the board what you would like us to do, they would like the MDC to do. But primarily the concerns that they've raised are regulatory, so it would require regulatory change, but it could look at all sorts of different options as far as what the solution could be. But primarily it's through regulations.
Dr. Sullivan, did you?
No, I was just commenting that there's a lot more research to be done. We're definitely going to have some stakeholder meetings and see what we can and can't do. But there's work to be done.
And if, say I'm starting a new practice, and why should I go to the expense of building a separate surgery room if they're getting by without needing walls? You know, why do they get an exemption and I don't? Anyway, those are the sorts of things we have to look at.
I do have a question, and it came up during the unlicensed practice subcommittee recently had a stakeholder meeting with the shelter community. And one of the questions to the shelter community was what are current hindrances to them, whether statutory or regulatory, that they feel are hindering their ability to provide the services to their community. And one of the things that one of the shelter vets had brought up is, and she performs high quality, high volume spays and neuters, is the requirement for the VCPR. And she had said that it's really challenging to do to talk to a client, 60 clients, if she's trying to do the high quality, high volume spays and neuters, and asked about the current ability for an RVT to act as an agent to establish the VCPR for vaccinations, and had asked about potentially using that and expanding it to allow an RVT to act as an agent to do the VCPR for the high quality, high volume spays and neuters. And we had said from the subcommittee that we could ask Animal Balance how you all are establishing that VCPR, and do you feel that that has been a challenge?
I do think it's been a challenge. I think that the RVT would be excellent. I think this is someplace that we've perhaps been falling short. On the communication issue, we try to have documentation, written documentation out so that they know what the risks are for the procedure and what the procedure is that's going to be done. But I would say that's someplace that we have a challenge, and I would agree. So when we were talking, when Ms. Pulaski was speaking about what our challenge, I don't think the surgery suite is the only situation. I do think it starts right with that the premise permit, the VPCR, and then the surgery suite are kind of the main areas. I think you've touched on the things that we have said are challenges. I do think the RVT thing would be an interesting solution that you mentioned.
Anything further from the committee? Okay, we will open it up to public comment in the room.
Hi, my name is Dr. Grant Miller. I'm the Regulatory Director at the California Veterinary Medical Association. Thank you very much for bringing this important topic to light. And thank you for this presentation and for educating us on how HQHVSN can be successfully performed to help California's pet overpopulation problem. The CVMA's board briefly discussed this concept this last weekend at our vision planning meeting, and their conversation was very similar to yours in terms of the questions that they asked. Some have HQHVSN experience on our board, others don't. And the discussion boiled down to that it appears that our minimum standards that Dr. Gedkin really succinctly pointed out, that our minimum standards for surgery appear to be in place for the prevention of surgical infection. So complications like bleeding and whatnot are going to occur whether you have room, whether you have a full door or not. But the door, the walls, the surfaces that can be regularly disinfected, those appear to be in relation to preventing infection. But as we discuss that more, we discuss the fact that I, as an equine practitioner, lay a horse down in the open air and castrate it right there out in the open. And I perform standing flank laparotomy surgeries. And Marie's probably aware of this too, that the incision is, 8 inches to a foot long. And these cattle stand out in the open air with their abdomen exposed, and there are no surgical problems. Now, the physiology, the nature of a horse, the robust nature of a horse or a cow as compared to a dog or a cat may be different. There may be some inherent behavioral, their body behaves differently. But it doesn't really appear that infection is a really huge issue, especially when the incision is 7 millimeters and they're in there for a total of about, I think Dr. Scarlett is telling me she's doing 7-minute cat spays now. I mean, and we know as surgeons that speed is an element, right? Speed is one of the best ways to avoid infection, is to go fast and be careful with tissues. So I think it's very important for the board to ask in the element of just with our own collective experience as surgeons, how many infections have we actually had? And do we need to have all these stringent regulations in place for patient protection when we know that between 660,000 and 1 million animals a year are dying in California's animal shelters because
15
we just
seconds.
have too many animals there. So I think it's very important to discuss it and really decide, like, do we need this in place for the HQHVSN? For regular veterinarians doing this procedure, it's understandable, but for those who are doing this specialized procedure that's fast
Time.
with small incisions, do we really need all this in place? Can I make one more comment in relation to the VCPR? I have one more minute.
Yeah.
So you had brought up, Jessica, just a moment ago, the concept of the VCPR in relation to HQHVSN and how that's actually working, because the VCPR does require some element of communication between the veterinarian and the client, which can obviously, take a lot of time. And I presented this to our board for the potential of running legislation this year to address that. And our board decided that it would be best for the CVMA to actually commission a task force to explore that very topic this year. And we will be asking Animal Balance to come give us a presentation to help us understand how this works. But we will be putting together a task force to look very specifically at the VCPR as it pertains directly to HQHVSN and what changes might need to occur in the VCPR to accommodate
15
that.
seconds.
Our board's initial reaction to having an RVT be an agent was not favorable, because RVTs don't have training in surgery to be able to answer those types of questions and communicate with the client. And so they're looking towards other potential solutions. So just be aware that we're doing that, and we'll be definitely reporting to the board any progress that we make with that task force this year. Thank you.
Hello, Bonnie Lutz. Most of you know who I am. I'm an attorney who represents veterinarians before the board following complaints and so forth. I just want to say that I agree with everything that Dr. Miller had to say. I just wanted to emphasize something that I'm seeing a lot of right now, and that is the informed consent issue. I know we don't call it informed consent in California, but it is part of the VCPR. And I'm seeing a lot of cases where my clients are getting dinged for not establishing that communication with the clients prior to doing a procedure. And that really concerns me with this kind of a setup. And I think there is something that there are things we could do to get around that, but I think that's a major issue we need to look at, because I know that it's a national issue as well. Because at Vet Partners, the AVMLA, the American Veterinary Medical Legal Association, is putting on a presentation of the informed consent laws and regulations in the various states. And some of you know that I do research in various states for a large company. So there are states that are very clear on what informed consent is, other states that aren't so clear, but I still think that we're going to have an issue with that, with the VCPR, with this kind of setup. So I just wanted to mention that. Thank you.
Seeing no further public comment from the room, moderator, would you please open it up for public comment online?
WebEx is taking public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand. And we will call on people in the order we have requests. And our first request is coming from Chesney Johnson. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hello, good day everyone. My name is Chesney Johnson. I am a pharmacy technician here in Oceanside, California. Pharmacy tech number 106559. One of the concerns, or one of the things that I would like to look for, like when clinics and stuff, is like a demarcation line. I know we're doing surgeries, but like in a regular hospital, we have surgical scrubs that we wear. So it would just be nice to incorporate that into veterinarian medicine. And we would like to see that as being a customer with our pet as well. Thank you and have a great day.
Thank you. And that was our only online request.
Okay, thank you. All right, since we're approaching noon, I think we will take a 1-hour break for lunch, and then we will resume with item 6 after that. Thank you so much for your presentation today. Okay, welcome back. We will continue with agenda item 6. That's going to be the update, discussion, and possible action on recommendations from the Unlicensed Practice Subcommittee. Dr. Nunez and Dr. Solicito.
So, as previously discussed in MDC meetings, October of 2024 and January 2025, the subcommittee was, amongst other things, tasked with pursuing legislation to narrow the scope of license exemption in Business and Profession Code Section 4827 to prevent unintended consequences. Specifically, the board raised concern with the owner exemption in BPC Section 4827, subdivision A1, and it being applied far beyond its intended purpose, which was to allow ranchers to provide veterinary service on their own food production animals. The board receives many complaints a year against unlicensed individuals who have allegedly caused significant harms to animal patients, despite the best of intentions, doing things that they shouldn't be doing under the protection of or the justification of it's their animals and they have the right to do so. The subcommittee held multiple stakeholder meetings over the last year to understand the various types of unlicensed practices occurring and worked with stakeholders to craft legislative proposals to help address unlicensed practice concerns. In April of 2025, the board ultimately approved legislative proposals that narrowed this owner exemption. Unfortunately, the legislative proposal was unsuccessful due to significant concerns raised by the shelter community. The shelter community felt that it was very important to keep that owner exemption because without it, there would be an influx of shelter animals for several reasons. They were concerned that the legislative proposal was overly broad and prevent owners from providing any kind of necessary care to their own animals. If owners were unable to provide services to their own animals, the shelter committee was concerned that the owners would just relinquish the animals to the shelters, which would result in an influx of more animals at the shelters. Similarly, rescue groups provide necessary care to their animals. The shelter community was concerned that if rescue groups were not able to provide the necessary care to the animals, they would stop taking the animals from the shelter. And if more members of the public relinquish their animals unless rescue groups take them from the shelters would far surpass the capacity and would be forced to euthanize more animals. And that is absolutely true. Their concerns were very real. And I would like to emphasize that the subcommittee or this committee as a whole, nor do I believe the Veterinary Medical Board has a desire to impede the great activity that these rescue groups are performing. And we definitely are motivated and desire to work with them to solve our pet overpopulation problem, especially when taking into account access to care issues and just the rising cost of veterinary medicine. There's nothing that we want to do to make that job even more difficult than it already is. So we decided to take a different approach. Instead of trying to just remove the owner exemption, we wanted to focus specifically on what was it that an owner was not allowed to do specifically. And we came upon surgery as being the main where we draw the line in the sand, so to speak. An owner cannot perform surgery on their pet, even if it's their pet. And the subcommittee met with council staff on multiple occasions to draft a legislative proposal that leaves the owner exemption intact but prohibits owners from performing dental or surgical operations. Specifically, the proposal would amend the owner exemption as follows. And then on page 2, there's a little bit of the proposal that was put forward. But before you read that, on October 9th, we submitted that language to a stakeholder meeting of various members of the shelter community. Could you mention some of the names of the people that were in attendance to that?
Yeah, so the stakeholder committee, we had members of the Cal Animals, which is the organization of a lot of the existing shelters. So we have Jill Tucker, who's the executive director. Yes, and then we also had Juliana Tetlow from San Diego Humane. We had Bruce Wegman of Shelter Pals and of San Francisco SPCA. And we had Cynthia Karsten of UC Davis, and Alison Cardona of the Annenberg Foundation. I think those were the primary attendees of the stakeholder meeting.
So in other words, there were big names in the shelter community. So we were excited that they were willing to come and listen to our proposal and give us their feedback. They had some concerns at the beginning of that stakeholder meetings about, once again, the veterinary medical board wanting to make it more difficult for owners to do, or rescue groups to do basic services like trimming nails or clean wounds and things like that. So the meeting started out with the usual talking points, but I think that the subcommittee and the staff did a really good job at trying to say that that's not the intention of the board. We want to focus on specifically surgery. We are a regulatory body, and our role in this world is to regulate the practice of veterinary medicine. And we believe that surgery is the practice of veterinary medicine, and that's where we have to draw our line in the sand. Dentistry has already been defined in the Practice Act. We don't really have a clear definition of surgery in our Practice Act. So the proposal in front of you is an attempt to define what surgery is and list also some exemptions to what surgery, what still can be permitted under owner exemption. The main additions after the stakeholder meetings was a line in there about vaccinations being given. So the legislative proposal that we are presenting starts on page 4 of this section. The new language is underlined. And in blue signifies.
So in blue was the additions from 1502, which at the time wasn't chaptered yet, but it is now chaptered. So it wasn't at the time current law, but it is law, going to be law now as of January 1.
So the definition that took us, we went back and forth on, was really the definition of surgery. 4827 1C For the purpose of this paragraph, surgical operation means any procedure performed on an animal which the skin or tissue of the animal is penetrated or severed, but does not include administration of injectable drugs, artificial insemination, castrated male livestock, dehorning, branded animals, subcutaneous insertion of a microchip for identification, ear tag tattoo, or tag placement. Initially, there were some members of the stakeholders that said that in that definition, doing a nail trim is severing cortified skin and therefore it's considered surgery. Again, we went back and said that is not our intention. We don't have the desire or the resources to go after illegal nail trims. So I will say that point over and over again. That's not our intention, our goal, our desire, or our capability to do that. I made a personal promise that we wouldn't do that. Everything else that's not underlined is already in the Practice Act. So that stakeholder meeting, and I'll talk about it after this, also included additional ask of what the shelter community needs from us. But that's our proposed legislation that we bring before this committee.
I just want to make one clarification. So in the memo itself, you're going to see on page 2, it differs slightly from the proposal itself on page 4, primarily because when this was written, you had C1, when administration of injectable drugs prescribed by a California licensed veterinarian. And then that part of it, the shelter community had concerns with that would prevent owners from doing other injectable drugs that are not necessarily prescribed by a licensed veterinarian. And so there's a lot of discussion with that. And so in your legislative proposal, you'll see that's where it differs, and I ends at injectable drugs. And after about an hour of discussion, there were some individuals who said that this is a really good compromise from where the boards started from. So they appreciated that we weren't eliminating the owner exemption completely, and it's gone a long way from where it started. So they appreciated that.
An example of a drug not prescribed by a veterinarian would be things like sub-Q fluids or a vitamin injection, things like that.
They couldn't hear your example.
Oh, an example of injectable medicine not prescribed by a veterinarian would be things like sub-Q fluids or a vitamin shot, things like that, which they can get from feed stores, online, Amazon. And again, there's part of the discussion was, protocols for the rescue organizations that are vaccinating their intakes, treating symptoms. Again, it's not a perfect system, but protocols are set up by California licensed veterinarians were part of the discussion. It's not specifically going to be covered on this legislative proposal. This legislative proposal was the other question that the stakeholders had initially was, why do we need this change? If an owner truly is doing something egregious, then that would fall under animal abuse laws that are in place. But the system doesn't quite work that way. The board has received complaints of fringe rescue organizations or individuals who may fall into the category of even animal hoarding. They start off with great intentions, but then they're doing things that they really shouldn't be doing. And they just have gone into a place where it may be difficult sometimes to prosecute because in some of these situations, you have to prove intent of harm by these owners of these pets. And that if legislative proposal was tightened up to prohibit the performance of surgery, then it would just make our job in stopping these bad actors from doing what they're doing. And I think the shelter community, that was a big holding point for them, is they didn't quite see the need for the change, most because they haven't seen the cases, and they haven't seen the cases because there's due process that must occur in any complaint where it just can't be revealed about the details of all these cases. So it's hard to really show them the numbers and the significant harm that's being done, but it is something that's going to allow this board to accomplish its mission of consumer protection if we had that language in place. So any questions about the proposed language changes on page 4 of your package?
So my question reading through this was if sub-Q fluids were included under drugs, because I don't normally think of them as a drug, but maybe I should. But it does include sub-Q fluids.
We wanted to avoid making lists of which drugs
Okay.
are going to be there and which drugs are not going to be there. But it's, again, a lot of it is going to rely on just the desire of the board. The board does have, our enforcement process does have the ability to make the call, on whether or not this is something that we feel is harmful to the consumer or not. And if you leave it ambiguous like this by saying injectable drugs, it could be interpreted as including sub-Q fluids quite easily.
Anybody want to make a motion?
Do you want to read that language? It's
On page 3.
motion to recommend.
All right, if the MDC agrees with the subcommittee's legislative proposal recommendation, I would like to make a motion to recommend to the board submission to the California State Legislature the legislative proposal described herein to amend BPC Section 4827 regarding unlicensed practice.
Second.
Okay, we will open it up to public comment in the room.
Hello, Grant Miller, California Veterinary Medical Association. One comment in relation to the proposed section 4827A1C, which discusses what a surgical operation means and then what the exemptions are to that. So under 1, there's the administration of injectable drugs, but there's another part to that I think may need to be considered. If we're talking about penetrating the skin, that means any needle that goes into the skin. And a lot of cattle producers actually draw blood for diagnostic purposes. They use it for pregnancy diagnosis. And so that might have to be something that you consider, or something you might want to consider to add in there. The other question that I have is that in the absence of any other definition anywhere in our law that talks about a surgical operation and what it means, even though it says for purposes of this paragraph, my concern is, of course, down the road, a broad application of a surgical operation, meaning a veterinarian giving an injection to an animal or a veterinarian giving drawing blood. Even though this is an owner exemption, it is statute. And if there's nothing else written anywhere else, then the law tends to gravitate towards that and say, well, a surgical operation can mean administering an injectable drug. So has the MDC subcommittee considered the potential any ramifications for this language being incorporated in statute, that we didn't?
It was.
So we can't have back and forth. We can talk about it after public comment.
I'm done. Thank you.
Seeing no further public comment from the room, moderator, will you please open it up for public comment online?
WebEx is open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand. We will call on people in the order we have requests. And our first request is coming from Carrie. If you are on a mobile device, you may need to hit the ellipses button. That's the ... in order to see your prompt. I'm sending you a prompt now.
Hello.
Hello, go ahead, please.
Hi. Okay, can you hear me?
Yes.
Oh, okay. Now I realize that I'm asking for clarification on part of the meeting minutes from July, which I'm assuming have been confirmed by acceptance of the July meeting minutes at this meeting on October, but it is germane to the unlicensed or the owner's exemption matter. So if it's not germane at this moment, I'm hoping that somebody can clarify it for me at this meeting. My concern is in the report given by Ms. Useri, it says at the end, I think somewhere in there, it says, quote, as a result of those concerns, the board proposed creating a first aid and husbandry exemption clause, which became BPC section 4827, subdivision A, paragraph 8. The board ensured this clause was worded carefully to avoid unintended loopholes and sought a balance between allowing reasonable care and preventing unregulated and unlicensed veterinary practice. The board voted to submit the amended proposal to the legislature. Now, my clarification is, what is the final disposition of the above action? Was this dropped, or is this going to be future legislation or addition or revision of the Practice Act going forward in the future, or what is? I'm just confused as what you're voting on today. Is that, do you intend to further revise it in the future in terms of owner's exemption? I'm sorry, it's so complicated, but anyway, that's my request for clarification within this whole subject of the owner's exemption.
Thank you for your comment. And there are no other comments online.
Okay, thank you. Oh, I have one more public comment in the room.
Yes, Bonnie Lutz. I have a comment about the definition of surgical operation as well. Having done this now for 25 years, I know that as the board changes and people making the decisions in enforcement change, interpretations of the statutes change. And sometimes that can be really frustrating, and I find it disturbing there's no other definition in the Practice Act of a surgical operation. So even though this says for the purposes of this paragraph, I can just see myself, although I don't think I'll be around in another 25 years, arguing that that definition of a surgical operation only applied to this specific section of the statutes. And so I think that that's a problem because there's no other definition. And again, I'm concerned, like Dr. Miller is, about that wording. Thank you.
Okay, it looks like that is the end of public comment. Any more discussion from the committee? Okay, if not, we can call for a vote.
Ms. Estuary,
Yes.
Ms. Bowler,
Aye.
Dr. Gatkin,
Yes.
Dr. Nunez,
Yes.
Ms. Pulowski,
Yes.
Ms. Sheffield,
Yes.
Dr. Solocito,
Yes.
Dr. Sullivan,
Yes.
Dr. Waterhouse,
Yes.
motion carries.
Okay, next we have
And I think they still have part B of their memo.
Part B of their memo.
Yes, after we hashed that legislative proposal out with the stakeholders, we just wanted to open up the forum for, I think Jessica referred to it as their pain points. What are their pain points? What makes it difficult to accomplish their mission of animal rescue, access to care, and so forth. And one of the biggest concerns was staffing, especially in the low-cost spay and neuter clinics, community centers. And a potential solution was given right off the bat of reciprocity between states, of licensure, getting veterinarians that are licensed in other states to have true reciprocity to come into this state to practice veterinary medicine. And that's a lot more complicated process than may initially seem, but work's being done to streamline that. And another issue that was talked about but not decided was the concept of limited licensure, creating a different licensing category of a shelter veterinarian, kind of similar to a university license, where university veterinarians can practice only within that university setting, possibly creating a shelter veterinary license where veterinarians can practice within that shelter environment. This also, the discussion was had with foreign graduates on their educational qualifications may not be similar, but is it adequate enough to practice in a shelter situation, in shelter medicine? Scope of practice for RVTs was also discussed as possible solutions to staffing. We're not going to talk about the other licensing category, which we shall not speak its name here in California, as a potential solution. And the other issue that was discussed was the VCPR, especially in the mass spay and neuter clinics, high volume. How do you establish that VCPR when you're working with so many different patients on a day, 2-day, 3-day event? And as Jessica was pointing out, we specifically were interested in the presentation today on how they established the VCPR at their clinics. So it's not a task that has been assigned to us technically by the board, but just other topics that were discussed that maybe the board may want to consider assigning as a specific task to the MDC. Was there anything else?
Yeah, I just wanted to add, with regards to the concern of the shelter community about not having resources, not having veterinarians, not having RVTs. One of the things that was discussed of the possibility of the special license that Dr. Nunez have mentioned. Again, looking at it from the perspective of if we are giving a special limited license to universities, for veterinarians that are foreign trained, being utilized to work on research, possibly performing the surgeries on lab animals and all that stuff. So is there an opportunity for foreign graduates whose qualifications in performing space and neuters will be, of course, established if there is a possibility of issuing a similar license? That was the part of the conversation. Another thing that the shelter community also expressed is the fact that with the VCPR, because they do more than I would say 50, 60 surgeries per day. And if they don't have the veterinarians to do the VCPR, because that means that would extend the veterinarians' hours from the intakes to finishing up the surgeries, doing their notes and everything. And they're already losing people at the shelters. The veterinarians are resigning, quitting the jobs because of all of this work. The suggestion of, is it possible to endorse the VCPR for surgery to their RVTs as an agent of the veterinarian for them, to basically share the load. Another concern that was brought up was the issuance of, I guess, animal control officers are allowed to perform euthanasia in emergency situations. However, they are not allowed, or they are not licensed to carry sedation. And so that is a concern that was brought up, that if it's needed in the field and it's the officers that are responding, do they need like a special license to carry like controlled drugs for sedation? So that was one of the things that was pointed out.
Just to add on to that, and that question was also if they are able to sedate. And so I think there were some questions regarding animal control officers and what they can do that I think is going to require a little bit more research in order to look at. But to make some clarification, when they were talking about the limited license for the shelters, they were talking, and Dr. Nunez mentioned reciprocity, and that where they were looking at is potential, and we said that these were all discussions too that we were having internally and looking at. And so there's two types where you look at potentially creating a limited license for a shelter veterinarian where you have more truer reciprocity, to where they don't, if they're licensed in another state, they don't have to then provide we don't have to receive the transcripts from the schools. We could just use basically the verification that they are licensed in another state, and the assumption is that those states have verified their transcripts already. They've already verified that they passed the national exam, and therefore would not require them to provide that information to us, and have true reciprocity for licensed individuals. So with the hope of them getting licensed faster to operate in the shelters. And then the other one being the foreign graduates. And when we talk about foreign graduates, these are not the foreign graduates who have gone through the existing foreign graduate pathways. These are the individuals who are unable to complete those pathways for whatever reason. They want to be able to have a limited license to provide these services in the shelters.
Does anybody have any questions for the subcommittee?
I guess I'm not understanding the question about animal control officers. We do have a section in our regs 2039.5 that I thought addressed the training of animal control officers to carry drugs in cases of sedation of animals.
It may just apply to euthanasia, I think.
No.
2935.
Oh.
Sure. 798.
Anyway, I didn't know what the reference was there.
Do you, in 2039.5, you're seeing the ability to say who is able to sedate? Because their question was if they are able to, if the animal control officers can sedate. And that's where I think there needs to be a little more research to find out what would prohibit them from doing that. But I'm just did a search for in 2039.5 and I'm not seeing sedation or sedate.
Yeah, it just,
well, it's a wide selection of medications that at one level is sedation that it isn't. I never got the impression when we were working on this that it was only euthanasia. If it was only euthanasia, it'd be euthanasia drugs.
Yeah, and I think that the question they just need clarification. And so when we said have to research the issues that they're finding, this is just a quick response to the question of what concerns you have. And so I think there's confusion there to look at.
Any other questions? We will open it up to public comment in the room.
Hi, Grant Miller, California Veterinary Medical Association. So those are all great think tank ideas, you know, for thinking outside the box. And I love the shelter community for always bringing forward ideas that we maybe haven't thought of. The one part that we're all looking for is not in regs, it's in statute. And it's the animal control officer tranquilization law that Cal Animals got passed, I think, I want to say 5 years ago. And it just says that they're allowed to tranquilize animals, which is not really what they're doing, but they're allowed to do that pursuant to regs that were passed by this board, to my knowledge. I think that's what it says. I could be crisscrossing it with the euthanasia training. No, I've got it right. Yeah, I've got it right. So there's statute that says they can tranquilize them in the field, but none of that matters. Doesn't matter, because what enables us to carry drugs in the field is the Veterinary Medicine Mobility Act, which is a federal act. And that act says that only a veterinarian can carry those drugs. So it's moot anyway. There's nothing this board, unless you want to, you know, go to the DEA and talk to them about changing federal regulations. There's nothing we can do about the legitimacy of them carrying the drugs in the field. Our state law says they can do it, but federal law says they can't. The difficult part about federal law is that the person responsible for that is the veterinarian, because they're the ones that are providing the drugs to the officers. And under the Veterinary Medicine Mobility Act, only veterinarians themselves are supposed to be carrying the drugs out in the field. Thank you.
Seeing no further public comment in the room, moderator, would you please open it up for public comment online?
WebEx is open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request online, do you wish to continue?
Yes, thank you. Any further discussion from the committee?
So I'm a bit confused. How are we getting away with it if it, Dr. Miller said, it's in our state legislation that animal control officers with proper training can euthanize pets, but at the federal level, according to the Mobility Act, only veterinarians can carry the drugs. And I know that all of our animal control officers are not veterinarians. So how are we getting away with it? Should we all turn ourselves in right now? You can't just drop the mic like that, Grant. So, or Tara, do you have an answer?
Tara Welch, Board Counsel. Several years ago, I had to write a memo for the board to describe the RVT's ability to transport drugs to rodeos as an agent of the veterinarian following the passage of the federal law. That was fine. They are an agent of another licensee and they themselves have to hold a license issued by the board. So I, already analyzed that situation, but as for ACOs, let's, put a pin in that. We can research it and bring it back to the board.
I mean, if we're getting around it by saying that the RVTs are agents of the veterinarians, euthanasia solution is much more powerful of a drug than sedation, then we should be able to get around it as well.
I am unfamiliar with the ins and outs of ACO practice on animals because they are largely regulated by a different code section. Yes, 2039.5 speaks to tranquilizers and euthanasia by ACOs. Otherwise, we don't really talk about their practice too much in the field. So I am unprepared to make any statements about their authority to carry controlled substances under federal law.
More research.
Okay, so it sounds like that's something we will look into a little further. Okay, moving on to agenda item 7, update, discussion, and possible action on recommendations from the Veterinary Practice Subcommittee. That's Dr. Sullivan and myself.
Well, something happened to my computer. Okay, I have the first section, which is on MASH, and my computer's died, so I'll just swing it. So the section on the presentation that we had on item 5, we covered and discussed quite thoroughly, and I, would like to hear any comments that this committee and the public may have on this, but I thought it was covered pretty thoroughly earlier. We definitely have a number of issues to work on the subcommittee. We are planning some stakeholder meetings to get other opinions and hopefully be able to create a workable situation that is both practical and defensible. And I think there are. We're going to have to be innovative, but I think that we can develop something along that line to satisfy everyone. The fact that they have more than one veterinarian in the MASH unit, I was happy to hear, because I didn't know how one veterinarian doing the surgery was responsible for communicating to the rest of the animals that are in recovery and whatever. So I think it's a workable situation. We just have to get some more, do some more research and come back with some ideas. I'll open it up. Now I'll see if I can get things here.
Do we have any additional discussion on that?
I was talking to Dr. Allison offline, and she's doing the MASH clinics in 6 states currently. And she had said that ours is the only state that has premise permits. And so that's the one of the big holdups that they're having for California.
We've gone over, especially being on AVSB, gone over a lot of practice acts. And there's not a huge difference from that aspect of the minimum standards. And I will be visiting one of those states that she listed tomorrow. So I'll get some answers from there.
And I
Give them hell.
Well, I can tell you too, just because I formed the North American Inspection Work Group, and we have states and Canadian provinces that all participate, and there's definitely a lot of other states and Canadian provinces that do require premises registration. So that's just factually untrue.
She may have chosen the states that don't have the premise permit to start off. Yeah.
Even most of them have minimum standards, whether they have a premises permit or not. And we just redid the AAVSB Model Act on minimum standards for practices. And there wasn't a lot of research needed. They're very, very similar. So, and we did it in ourselves here, and we researched, CVMA provided a number of examples. I think they reviewed all of the states. So when it comes to minimum standards, there's not a lot of variation there. So we'll see.
Well, I mean, Dr. Miller's point about doing surgery out on the ranch in the open doesn't increasing the amount of infection that occurs in those surgeries makes you wonder how much does really that closed door help? And what was that requirement based on all those years ago?
I don't have an answer to that other than there is a tremendous species variation there. Selection may be a part of that, but I think we have to have some consistency here. What our end product is going to have to be workable, whether it is in a small animal practice, in a MASH unit, or in a fixed building unit. I mean, we can't have a huge this board or the board can vote on whatever they want, but my opinion is it's got to be somewhat equal and level. We can't have two hugely different standards. And they are doing it here with comparable results. So let's help them out. But I don't think we throw everything out the window.
Yeah, I just want to kind of put my 2 cents in worth on the chance of infection doing surgery outside versus inside. And I think COVID taught us something there, that we were much less likely to catch COVID if we were outdoors, but we were much more likely to catch COVID if we were indoors. Sorry, did everybody catch that? So that COVID taught us that, we were much less likely to catch a respiratory infection if we were outside, and much more likely inside. And so outside, as long as the wind isn't blowing, then have I done surgery outside? Yes, I have. But I also grew up on a farm. But I think indoors, in a confined area, just with clipping of hair, it's going to be in the air, and all people moving around and animals waking up and starting to move around. There's going to be more stuff in the air than there is outside.
Can I just add that the surgery being performed, the technique, and like how this space and neuter is being done should be taken into consideration with regards to the possibility of, like, why would it be different for a fixed premises surgery area compared to what a MASH clinic would need? The surgeries being done is different. That I would have to say, looking into what is the activity being done, not all surgeries are the same. So maybe that's a consideration to be made.
Yeah, that's a good point. I asked the doctor what the world record was on a spay, and she said that someone did a cat spay in 3 minutes. And so the amount of time that body cavity is open for 3 minutes, definitely a small window of opportunity for infection to take hold. So that may be a good justification to allow exemptions in that surgical confinement that the surgical door establishes. Because these clinics are rapid surgeries.
Okay, if there's no more discussion from the committee, we'll open it up to public comment from the room. Seeing none, moderator, would you please open it? Oh, one moment, we do have one. My apologies.
Just one simple comment. Approximately a third of the states have premises registrations. A third are required to be owned by veterinarians, and a third don't have either one of those requirements.
Okay, seeing no further public comment from the room, moderator, would you please open it up for public comment online?
WebEx is open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request online, do you wish to continue?
Yes, thank you. Okay, so part B of agenda item 7 is challenges related to licensee manager requirements. So the rulemaking referenced above is also included. It also included the following minor revisions to CCR Title 16, Section 2030.05, where you'll see some cleanup language where facilities were changed to veterinary premises, permits were changed to registration, and then there's some additional references or some changes to some references in there, but most of that was just cleanup. Additionally, the board's executive officer and enforcement managers have shared significant concerns with the licensee manager structure and the lack of accountability for the veterinary premises owners. I'll go over some of these concerns, but I invite any of them to give further details if I miss anything. The licensee manager tends to be a rotating door. So although this licensee manager is the sole individual responsible for ensuring the veterinary premises satisfies the minimum standards, the premises owner is often not the licensee manager and can be an unlicensed individual or entity. The board hears from licensee managers often that premises owners will not approve or pay for necessary changes for the premises to comply with the minimum standards. This results in a rotating door of licensee managers coming and going, each new one trying to bring the premises into compliance, only to leave frustrated when the premises owner refuses to make the necessary changes. Meanwhile, animal patients continue to be treated at the premises, and this occurs in potentially unsanitary conditions, and the unlicensed premises owner may continue to have unfettered access to controlled substances within the premises while all of this is going on. It leads to repeated inspections. So the rotating door of licensee managers often leads to the need for repeated inspections and delays in compliance. When the board completes an inspection, the licensee manager is typically given 30 days to make any necessary changes within the premises. However, when the manager changes, the new licensing manager is often given additional time to make these corrections since they were not responsible for the previous conditions. Depending on the severity of the violations, this could lead to inspections being repeated while the new licensing manager works towards compliance. No citations for repeated violations. So most inspections result in minor violations that the inspectors educate the licensee managers about and work with them to obtain compliance. Typically, once compliance is obtained, those inspections are closed with no action. If the same or similar violations are found at a subsequent inspection and the licensee manager is the same, a citation is issued against that manager. However, if the same or similar violations are found at a subsequent inspection and there's a new licensee manager, it's difficult to issue a citation against the new manager as they were not responsible for or educated on the violations from the first inspection. So while the violations were repeated at the same premises, they are treated as if they were found for the first time. Amended pleadings. In an accusation filed in formal administrative disciplinary cases where a veterinary premises registration is listed as a respondent, the licensee manager is included with the registration because of the licensee manager's responsibility for the violations alleged in the accusation. Within the last several years, numerous accusations had to be amended to remove the veterinary premises registration following substitution of the licensee manager. Again, the new licensee manager would not be responsible for the prior premises violations, even though the premises registration holder may be impeding compliance with minimum standards. Further, the licensee manager cannot enter into a stipulated settlement for the veterinary premises if they do not hold the veterinary premises registration. Thus, accusations are now only filed against the licensee manager and the veterinary premises registration if the licensee manager is the premises registration holder. Otherwise, the veterinary premises registration and the unlicensed registration holder is left out of the pleading. There's a general misunderstanding of licensee manager duties. So many veterinarians do not understand the difference between minimum standards for a veterinary premises and the standard of care. Some veterinarians have shared concerns about becoming a licensee manager because they did not want to be responsible for a veterinarian within the premises providing treatment that was below the standard of care. Other veterinarians have shared that they never understood what their responsibilities were when they agreed to be a licensee manager. And once they did, they decided to no longer serve in that role. An example of this is one veterinarian who contacted the board because they wanted to volunteer to perform spay and neuter services for a veterinary premises. The premises owner informed the veterinarian that they would need to be the licensee manager to volunteer, but they would only be responsible for the minimum standards within the surgery suite. After providing the applicable code sections to the veterinarian, they decided not to serve as a licensee manager. Shelter difficulty finding licensee managers. So we've talked a lot about the shelter community today, and their representatives have previously shared with the board on multiple occasions their challenges in finding veterinarians who are willing to take on the responsibility of licensee manager. This has made it very difficult for them to obtain premises registrations and to provide necessary care to animals within the community. There's no cap on the number of premises that can be listed under a licensee manager. So currently, a licensee manager can be responsible for an unlimited number of veterinary premises throughout California. The licensee manager is required to maintain whatever physical presence is reasonable within the facility to ensure the minimum standards. So there's no set number of times that they need to be there in any way, shape, or form. So with that, it's hard to say that they're sure that there's no unlicensed practice occurring on the premises. This means there could be one manager for 20 plus veterinary premises throughout California, and the same licensee manager may also reside in another state entirely. Veterinary premises staff are unaware of who their licensee manager is. So inspectors have reported on several occasions where larger veterinary premises staff are often unaware of who the licensee manager is since they have never stepped foot on the veterinary premises. Thus, the veterinary premises staff are unaware of who's accountable for the minimum standards or who to communicate with regarding any outstanding compliance issues. Recent action in another state. In June 2025, the Virginia Board of Veterinary Medicine took action against 3 corporation-owned veterinary premises for operating for multiple years without a veterinarian in charge, which is their form of managing licensee. In that case, the corporation owners submitted registration forms for all 3 establishments, all with signatures of VIC, who had no knowledge that he was listed as VIC for multiple years. There are concerns these violations are not unique in Virginia and are occurring nationwide, including in California. The subcommittee shares the board staff's concerns that the current structure holding the licensing manager accountable for all minimum standards within the premises, especially when that manager is not the owner of the premises or the registration holder, may not be adequately protecting consumers or animals. Instead, the regulatory structure designed to protect consumers and animals may be providing a false sense of security while enabling owners to continue operating these premises well below the minimum standards. The subcommittee would like to discuss these challenges and explore a potential solution to remove the licensing manager requirement. Instead, the veterinary premises registration owner would be responsible to ensure all minimum standards within the premises are met. This would likely require significant research and stakeholder engagement to ensure consumers, animals, and veterinary premises employees are adequately protected if the licensing manager requirement is eliminated. Topics such as medical records, ownership, applicant fingerprinting, drug enforcement, impacts, identifying responsible parties for large corporations, other things like that will all need to be thoroughly discussed. Before researching this issue any further, we would like feedback from the MDC and guidance from the board on whether this should be pursued or if there are alternate solutions to be explored.
And go.
Yes, it should be explored. Yeah, I think this is one of the best things that we could talk about. I think it's probably brilliant, and I appreciate our EO, but yes, this is, when it was discussed, I think it should be celebrated. I think that we should talk about it. It is critical, and I think it would be brilliant. So yes. Anything else from the committee?
I mean, my initial reaction is that the licensing manager is responsible for ensuring that the premise for which they are managing complies with requirements. And the licensing manager is a veterinarian. What I hear is being proposed is that the licensing manager now is going to be the practice owner, who may not be a veterinarian.
No, so what's being just discussed, so not even proposed, just an option, an
Yes.
alternative, is removing the licensing manager requirement completely, and all of the accountability and responsibility would be on the veterinary premises owner, whoever that might be. So it could be a veterinarian, but it also might be the unlicensed individual who owns the premises. They would be the ones ultimately responsible for making sure that their premises complies with the minimum standards.
How difficult would it be for us as a regulatory body to supervise or manage non-license holders?
So I think there's a lot that has to be researched in here, but the thought is that the owners, who we'll already have to know who the owner is of the veterinary premises, would be the ones who are accountable. So if there are, just like if we get complaints that there's minimum standards concerns that we do an inspection for, or if we go out and do regular inspections, that owner would be the one that's responsible. So we would be able to issue the owner itself a citation if they were repeated.
So
if
a VCA hospital is owned by a corporation, it's owned by Mars.
Yeah. So I think that that's going to have to be looked at to see who for corporations would be held responsible, but there's other similar models within DCA structure, like the Board of Pharmacy, and I think the Board of Optometry recently has a way of holding the individuals that are higher up in the corporation accountable to making sure that their location is up to their standards.
And this would be a win for shelters?
I can't speak for the shelters, but I do know that the shelters have shared one of their frustrations being that their licensing managers aren't able to find veterinarians who to serve as licensing managers. So then it makes it challenging for them to maintain a premises registration because the veterinarians aren't able or aren't willing to take on the responsibility of the licensing manager duties. And this was mentioned in the shelter stakeholder meeting and didn't seem opposed to that idea at all.
Tara Welch, Board Counsel. I just want to clarify something real quick. We need to be mindful of the difference between a premises owner and an operator. Right now, to obtain a premises registration, you have to be the owner or operator. So I'm thinking in terms of, premises itself means the location, which is brick and mortar or the mobile unit, like the vehicle. So you may not own the brick and mortar, maybe you're leasing that facility, but you have applied for a registration for the veterinary premises, which is the location where veterinary medicine will be practiced. So, when we're thinking about these issues, I'm going to be mindful of the difference between the brick and mortar owner, the operator of a premises, and then the registration holder. So I think what we're talking about is maybe moving toward the premises registration holder being responsible for maintaining the minimum standards at the premises.
Could you give me an example of who would be the premise operator of a VCA hospital?
So I own a building. It is rented by a corporation who operates the facility. And they rent from me as a corporate veterinary hospital. So they are now the ones responsible and would be the managing licensee, but we're not having a managing licensee, but they would be the ones responsible for the premises.
But what if it's the other way around? If it's the corporation that owns the building and the people that are in that building running the hospital are employees of that corporation. They're the operators, but they're also the employees.
Well, whoever owns or holds the premise registration, that's the key. We need to move away from premises owner or operator and think about in terms of when we want to hold someone responsible for minimum standards, we are looking toward the premises registration holder.
Yeah, I just think that finding somebody to be held accountable would be challenging when you make this change. If you make this change.
And again, I don't think we're going to solve it all today, but because it's going to require a lot of research. But I think before anyone does that research, we want to make sure that we're not crazy and that everybody doesn't hate this idea.
We're not going to come to that conclusion either.
Because we can't resolve it because we can't do it now. Look at all the problems we have with it now.
Yeah, the current structure is concerning.
Dr. Goodkin? Yes, I agree that this needs to be revisited, but I also agree with Tara that when we started talking about premises owners, I'm thinking about the building owner. A premises is a physical location.
Yeah, so to be clear, when staff were talking about owners, we're talking about the premises registration owner. So who the premises registration is issued to, they would be the ones responsible for the minimum standards.
And just to clarify that the Veterinary Medical Board only has jurisdiction over registrants.
Right, registrants and licensees.
Correct, not necessarily lay people that own a building.
So if lay people own the premises registration, we have authority over them.
Correct. So that would be a veterinary board registration of, okay. But I do think, yes, as far as enforcement goes, the licensee manager does muddy waters when we have consumer complaints as well, because the drop down for consumer complaints right now is you hit veterinarian, veterinary RVT, veterinary premises, something like that. so many complainants right now hit veterinary premises, and we won't know who the veterinarian is that actually treated. And so we're ending up now with cases, like 9 cases against one licensee manager who has never touched the animal because she's listed as the licensee manager. If that complainant doesn't clarify and we don't get information on who the veterinarian is. So they're the roundabout way, because ultimately they're responsible for making sure that the board gets records if requested. And let's say the veterinarian that the complaint was about 3 years later isn't there. Many ways can kind of muddy up the waters. Let me just put it that way. And I think it's taking a lot of time now to try to piece out, no, that's just the licensee manager, but the complaint is actually not against the licensee manager, sometimes just how it drops down and how just kind of muddies the water there. So.
I just had a question going forward. Assuming the board would like to engage in this research and discussion, which seems really important because clearly there's confusion and it's not getting resolved on its own. Would there be stakeholder meetings, additional research, additional outreach, and then coming up with some solution in the future? Is what would be the next steps? Okay, thank you.
Yeah, and I can even imagine a scenario where all of a sudden VCA has suddenly 3,000 complaints against it because they're the premise holder. And maybe they'll decide that the cost of doing business in California is not worth it. And how would that serve the consumer? And I'm not being paid by anybody to say that, but it's just holding somebody accountable, it would be difficult. Just things to think about.
Okay, anything further from the committee?
Just to clarify, so is the consensus is that the MDC is saying, yes, we would like to proceed, and so we can let the board know tomorrow that you are recommending that we proceed with this research and try to address the concerns?
Okay. All right, we will open it up to public comment in the room.
Okay, Bonnie Lutz, I have several comments. First of all, why are you removing the specifics of the Business and Professions Code in the very beginning there, where you're just saying code? And I'll tell you why. Because I'm dealing with a lot of these corporates, and they have attorneys from other states. And in other states, the Business and Professions Codes are found all over the Practice Act. For example, in New York, it's in the Education Code, which makes no sense whatsoever. So I'm having attorneys from these corporates call me and reference statutes and regulations that are not part of our Practice Act because they do not understand what code they're supposed to look in. So I would really suggest that you try to be specific when you're making changes like that and not remove the Business and Professions Code section and just call it the code. More importantly, I wanted to talk about the issue related to the managing licensee. And I'm sure that some of you are aware of this, and probably Jessica is, that North Carolina just went from being what we call a PC state, meaning that it had to be owned by veterinarians, to a permit state. But the regulations specifically state that the licensee manager, and I can't remember what that person's called, but whoever that person is, the managing licensee, reports any violations of the Practice Act to the owner of the practice. And if there is any kind of discipline, the discipline is against the owner. So it's specifically in their new regulations that apply to this person that even though there is a managing licensee, the owner is responsible, and the managing licensee's responsibility is to report it to that owner. So that might be something you might want to consider. The other thing is Massachusetts which is not a permit state, they do have what's called a medical director. They require a person called a medical director, and that is the person that addresses all the issues with the compliance with the Practice Act. As far as the initial letter being written to the licensing manager, we deal with that all the time. And it seems that it's pretty easy once we submit the records to the enforcement staff that they're able to identify who the actual veterinarian was. So
15
I
seconds.
understand what Dr. Gutkin is saying, except that we find that in reality, that happens pretty fast, that they realize who the actual vet is. Thank you.
Grant Miller, California Veterinary Medical Association. I think these are great topics. I get calls all the time from veterinarians with confusion about the licensing manager and who is that person? What are they supposed to do? And it seems like it's a natural progression for this board to address these things, because no longer are we in the day where the veterinarian is the owner and everything all boils around them. You know, these practices are now becoming greatly divergent in the way that they're owned and run, and with all the corporations and conglomerates and everything that's out there. I think it's just a good use of board time and energy to be addressing these topics and maybe some other ones. I'd say that out of these, the ones that are in particular, the ones that are the most common that I find are the shelter, the difficulty for shelters to find the licensing manager, to be the licensing manager for them. And then also the veterinarians wanting to be the licensing manager for multiple locations. And that can be problematic because they have to maintain some kind of physical presence at those locations, and how much is enough, it's hard to really know. So I feel like those are really well documented on there and should be discussed. And there'll probably be other topics that start to come up as this is looked at more. So I definitely support the MDC looking into this more, or the board assigning a task force to take a look at it. Thank you.
Okay, seeing no further public comment from the room, moderator, would you please open it up for public comment online?
WebEx is open for public comment online. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. And our first request is coming from Chasney Johnson. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Good day, everyone. My name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I would like to give some feedback for managers, because it does take a lot to be a veterinarian director or manager of a facility, and you don't want to diminish the basic knowledge that everything that you went to school for. My first suggestion is to be more aware of the premises surroundings. For example, if a pet hospital is located inside a pet store, it would be nice to see no cardboard boxes being stored on top of the shelves. If that's not allowed in a real hospital, why should it be displayed in a pet hospital? My second feedback suggestion is sometimes the receiving area has a door when you're shopping or visiting the pet hospital, and you can see the workers inside stocking things. We want to make sure that if there's machinery, there's safety vests, so it gives a visual indication to help ensure the business is following OSHA compliance within the business that is practicing healthcare and medicine. Thank you for letting me participate today, and have a great day.
Thank you. And that was our only online request.
Thank you. Okay, if there's nothing further from the committee, we will go on to Part C of Agenda Item 7. Part C is the condition-specific VCPR. A little bit of background on this. During the July 2025 MDC meeting, the Complaint Audit Subcommittee shared recent discussions from a subject matter expert roundtable regarding the condition-specific VCPR. Specifically, the subject matter expert discussed a scenario where a veterinarian established a VCPR to administer vaccines to a healthy dog during its annual wellness visit. 4 months later, the client called the veterinary premises reporting the dog had diarrhea for 4 days despite a bland diet. The clients reported the dog was eating normally, not vomiting, and had normal energy levels. In this scenario, the veterinarian was unable to see the dog for over a week and recommended the client submit a fecal sample for the animal patient, which tested positive for Giardia. The veterinarian called the clients to discuss the results and prescribed medication without reestablishing the VCPR for the Giardia condition. Many SMEs present agreed that they would have done the same, suggesting that this might reflect a standard of care that conflicts with current law. As such, the Complaint Audit Subcommittee requested the MDC and board discuss this further and decide whether the current condition-specific VCPR should be changed. The MDC discussed the following: current law versus practice. So under current law, the VCPR is condition-specific and must be reestablished to treat new conditions. Telemedicine can be used to reestablish the VCPR, but the law requires that all disclosure and warning requirements be met. In the scenario provided, the VCPR was not reestablished, yet most reasonable veterinarians indicated that they would have prescribed the medication in the same situation. COVID-19 waiver context. So during COVID-19, a temporary waiver allowed veterinarians to diagnose and treat new conditions via telemedicine if an initial in-person examination had occurred. This period lasted about 18 months to 2 years. Some participants thought there had been broader condition-specific relief, while others clarified that the waiver was primarily tied to extended prescription timelines. Standard of care versus regulation conflict. So several of the subject matter experts noted a tension between the legal requirement for a condition-specific VCPR and a common veterinary practice. The hypothetical scenario raised the broader question of what should happen when the standard of care conflicts with the law. Some suggested adding qualifying statements or clearer guidance to help avoid confusion among subject matter experts when reviewing cases. There were some differing perspectives. So some of the participants viewed fecal testing as part of the wellness care, tying it back to the prior VCPR, while others emphasized that the law clearly requires a reestablishment of the VCPR for the new condition. Concerns were raised that a strictly black and white interpretation could lead to inconsistent case reviews depending on the approach of the subject matter expert involved. Access to care and spectrum of care considerations. In situations where clients cannot afford or access in-person visits, alternatives such as fecal testing may be more reasonable. This led to questions about whether the condition-specific VCPR requirement limits access to care in certain cases. Future implications. It was noted that long-standing statutory requirements could influence how new graduates interpret and apply the standard of care. Over time, this could shift veterinary norms towards stricter adherence to condition-specific rules. During public comment, Dr. Miller from CVMA emphasized the importance of the current discussion and stated the CVMA is considering legislation on this issue for the coming year. Dr. Miller highlighted that the condition-specific interpretation of the law significantly impacts access to veterinary care in California. The high cost of veterinary care, partly due to this interpretation, prevents many pet owners from seeking care. He noted that the VCPR law in California is not fundamentally different from those in other states, but California's board uniquely enforces a condition-specific interpretation. He urged the MDC to reconsider the interpretation. Nancy Ehrlich, RVT from CARFTA, echoed his sentiments and encouraged the MDC and board to also reconsider the condition-specific interpretation. The MDC shared the discussion with the board during their July 2025 meeting. No recommendations were provided. During the board discussion, it was clarified that the VCPR statute refers to the animal's medical condition in the singular, a long-standing interpretation. This interpretation was discussed at length during the telemedicine discussions in 2020, and there was agreement within the profession that the VCPR was condition-specific. Board members discussed the potential to remove the condition-specific language and replace it with a time limit, such as an annual contact or examination. This would allow a veterinarian to use their professional judgment whether a VCPR should be reestablished within the year, given the circumstances of each patient. One board member emphasized the importance of standard of care over strict legal interpretation, arguing that if the law overrides clinical judgment, expert witnesses become irrelevant. The profession should be guided by its training and evolving standards. Board members shared concerns that strict adherence to the condition-specific rule could delay care or force costly emergency visits, ultimately harming consumers and patients. After hearing public comments like those made at the MDC meeting, the board decided to send this matter to the MDC to determine whether the VCPR statute should be amended. The subcommittee notes the following different perspectives on whether the VCPR should remain condition-specific for the MDC's consideration. Support for removing condition-specific language. So removing this language allows veterinarians to determine whether they have enough information and knowledge of the patient to decide whether the patient needs to be examined for a new condition. In the Giardia scenario, it could be argued the standard of care was followed since most subject matter experts would have provided the same treatment without reestablishing a VCPR. Enforcing the standard of care would sufficiently protect animals without requiring an examination most veterinarians feel is unnecessary. Should the patient's condition worsen following a given treatment, then the veterinarian should request an in-person appointment, just like the guidelines for dispensing medications from telemedicine consultations. Removing the condition-specific language can aid with access to care issues from multiple angles, such as appointment availability, lack of adequate means of transportation, and financial feasibility. If the condition-specific language is removed, the 12-month requirement for a new in-person examination would remain for prescribing controlled substances. There are also concerns for removing condition-specific language, which included that if this language is removed, there's a concern veterinarians would become or enable pill factories, which dispense medications over a phone call with little or no attempt to visually evaluate the patient. BPC section 4826.6 subdivision I4 or 1.4 states a veterinarian who established the required veterinary client-patient relationship using synchronous audio-video communication shall not prescribe a drug to the animal patient for use for a period longer than 6 months from the date upon which the veterinarian examined the animal patient or prescribed the drug. The veterinarian shall not issue another prescription to the animal patient for the same drug unless they have conducted another examination of the animal patient, either in person or using telehealth. If the condition-specific language is eliminated, a veterinarian could establish a VCPR by telehealth and 6 months later, and therefore indefinitely thereafter, prescribe a different drug for the same medical condition or a new drug for a new medical condition without ever re-examining the patient. The VCPR itself does not expire. There is a concern that eliminating the condition-specific language will reduce consumer protection because it lowers the bar of prescribing a drug even more. Prescription drugs used in veterinary medicine are not over-the-counter drugs. Many NSAIDs in human medicine are over-the-counter. In the veterinary medicine world, they're of higher concentrations and are more comparable to prescription NSAIDs in human medicine. So we were asked to consider all perspectives and discuss what is best for the consumer, consumer protection. So we welcome any discussion, thoughts on this topic. Dr. Sullivan.
Yeah, I'd like to modify my comments towards the end there. After thinking this over more, this would be the bottom of page 8 and the top of page 9. My concern really is concentrated around those companies that just do telemedicine and just sell drugs, sell pills. They have no intention or no concern about a specific diagnosis or the treatment plan for the animal. And if we don't have the condition-specific regulations for them, they can just keep switching the NSAID for 3 or 4 times without even taking another look at the animal. So I think I would modify my statement in this is to, because I get the need for removing conditional specific. And I think if we have a company that does telemedicine from a fixed property, like I think the larger shelter programs do, they have more options. They can get the client to come in and check the blood test with, and keeping that cost to a minimum. But the companies that have no intent on doing that have now a lower bar to dispense their products. So I guess I would redefine this comment to say that I would like to see the condition-specific requirement kept for all of those practices that don't have a premises permit. Thank you.
Go ahead, Dr. Goodkin.
So I believe that the point of the VCPR is honestly, the way I'm interpreting this, even in telehealth, is to get a visual on the pet, right? Because here's the thing, by regs or by how we interpret regs, you can tell me that I have to get eyes on a dog that I've known for 10 years and have a relationship with this client, XYZ, to collect enough information, I guess, for me to proceed with a possible diagnosis or treatment. That's about it, because you're not telling me what my exam is, right? So is the point just to get eyes on a dog or cat? This is where I have the problem. For this diarrhea dog, even if you got eyes on him, you're not stopping a veterinarian who may not be practicing the quality of medicine that is minimal in your head from just prescribing the pills, right? We're not saying you have to get eyes on him and take a weight and palpate his abdomen. We're not even saying that. So in my head, it's more of a barrier for veterinarians that are trying to practice the quality of medicine that I think is in our heads. I don't think this is a barrier to prevent necessarily, I think, the pill factories or anything like that, because even then, we're not, if for the bare minimum, if it's okay, now reestablish this VCPR by a visual exam, right? You're going to find a way around it. So I'm just going back to professional judgment. We're already putting professional judgment of what an examination is in the hands of veterinarians. Period. So I'm thinking, why aren't we putting the professional judgment on reestablishing a VCPR for a different issue of a pet that you already have a general VCPR with? Why aren't we leaving that up to professional judgment?
I'm confused because, I mean, you and I both are consultants and we see cases. And so, yes, when I see someone that is seeing a dog for diarrhea and they don't do a physical exam, so that's going to be a problem. So I don't get where you think it's okay just to do a visual exam and not a physical exam. So I think a physical exam, if they're
I'm
bringing,
incorporating the newer telehealth.
okay.
Establishing a VCPR by telehealth would do, right? We have to remember that. It's already here. So,
but it's
in my head, even if we're going to keep that, there's no real requirements in telehealth other than there's no real requirements that I think is going to force a veterinarian to collect more data if they feel like they have enough data to make a judgment on that ear infection of a lab I saw 2 weeks ago or 5 months ago, but it is a chronic thing. To reestablish a VCPR.
Now, the ear infection I will argue with, because you don't know if it's yeast or bacteria just by the fact it had one infection a year ago or whatever.
That's true. You insert anything, insert the Giardia one, like we'll just go back to that. If I could reestablish that VCPR, correct me if I'm wrong, by telehealth, correct? Without laying hands on that animal, which is legal now. And we can't argue that. It's already here.
I hate telehealth.
See, and that's the
it's
thing. We're
inappropriate.
so wrapped up
Yeah.
on telehealth, good, bad. It's here, period. Period. So now we have to be interpreting VCPRs with telehealth, right? So I'm going, what is the difference then of me reestablishing this VCPR? You want me to get a look with an otoscope? Well, I reestablished it. And look, yeah, okay, that's, oh, does it smell? Yeah, it's really bad. Okay. that's technically okay now. Now, I'm not saying that's my standard of medicine, but telehealth has changed, I think, more of VCPR establishments than our brains have embraced. Does that make sense? So I really want to be cognizant of when we are enforcing the basis of a veterinary relationship, what is the real point of that, right? If I could just look at the dog and say, okay, that was my requirement on telehealth or something like that. Now here's your fenbendazole. Now that's a charge. Now I'm getting a complaint going, they charged me $150 and they didn't do anything, right? And that's also eroding the public's confidence in the veterinary profession, which ultimately does not serve the public. We see a lot of those as consultants, right? He didn't do anything. He didn't do that. And now I have a $150 bill. That's also something I'm concerned about for public as well. So again, just being really cognizant on the fact that the VCPR establishment, how we establish that has changed. Now we have to be cognizant on, okay, to reestablish that, I don't necessarily have to put hands on that dog. And it's here.
Anything further from the committee?
It gets a little, establishing a VCPR, I think, is one thing. The questioner is diagnosing and treating a new condition when you've already established that VCPR is a different, unique question. Because I've already established physically a relationship with this dog that was an example, and he came in just for a wellness exam, but then the new condition was Giardia. I think that in that situation, as most veterinarians would, it's reasonable that you can make a diagnosis and treatment because you've already established a VCPR. But it gets complicated because what if you make a misdiagnosis virtually, you're still held as accountable as if you would have made a misdiagnosis in reality.
And I'd like to point out you're correct, and that is on the veterinarian's professional judgment, right? If you do make it, if I'm going to do that and I'm wrong and it turns into something, I made the judgment to do that, just like I judge what my physical exam is. So we are still putting the onus on the professional judgment of that veterinarian. And I do believe now what you're talking about, this case, this is where it gets gray because it's interpreted right now as you have to reestablish that VCPR. And correct me if I'm wrong, Jessica, right? So correct me if I'm wrong.
Yeah, so for argument's sake, in this scenario, the VCPR, it's a totally different condition, would have to be reestablished.
Dr. Sullivan's solution would be to make a distinction between a VCPR that was established at a brick and mortar facility versus one that was established virtually?
No, in essence, yes, but I mean, what the wording would be that because if you're just doing telemedicine, you're not required to have a premises permit. So the language would say that in essence, the only condition-specific requirement would be if the practice did not have a premises permit.
Registration.
Pardon?
Registration.
Premises registration? I'm sorry.
So if you had
How many years has that been?
a premise registration, you could make a new diagnosis on an existing VCPR. But if you did not have that premise registration, you could not make a new diagnosis on an existing VCPR.
You would have to reestablish the VCPR virtually.
Okay. I like it.
And in 6 months to refill any medication, you'd have to reestablish the VCPR virtually again. So it's just requiring the responsibility of taking a look at that animal every time you're treating it with a new medication or refilling a medication over 6 months. And that's a really low bar. In the other scenarios where there's actually the ability to do follow-up because you're working from a premises registration, there's better oversight there. They may not use it, but then that's up to them.
I'm sorry. So if you do have an established VCPR from an established premise permit
registration, yes,
you can make a new diagnosis within 6 months.
Well, you no longer have the condition-specific condition for the VCPR.
After 6 months.
Anytime.
You're comfortable with it, you would not have to.
If we're removing it, I'm saying I'm okay with that.
Okay.
With all of the conditions, all of the recommendations, all the issues that have come up, access to care, et cetera. But I'm not okay with doing it if the only thing you're doing is dispensing medication and you don't have a premises permit. Then I think they need to be looking at the animal more.
So you're okay with removing it?
I'm sorry?
You're okay with removing the condition-specific part?
Except for that one condition, yes.
Dr. Sullivan, can you clarify practicing telemedicine in California, dispensing, so sending a prescription off to Chewy or something? Is that what you mean by dispensing?
Pill factories.
Prescribing or dispensing. You can establish it virtually if that's all you're doing. If all you're doing is telemedicine, you don't have to be you don't have to have a premises registration. So we can't look if they've got unlicensed activity there. We can't look at their medical records unless, I guess we can request them through the client, but there's no inspection going on there. So I think this is the least level that we could ask.
So excuse my naivete, but how, is that a big problem in California?
Well, I want to clarify, we absolutely can enforce unlicensed practice. So if that is happening, we can still do that. There's not a physical location that we're going to inspect, but they're still required to maintain medical records but they don't have to have a premises registration. So unlicensed practice is still enforceable and medical records is still enforceable.
But we're running into the problem that we don't have somebody to go after if they don't have a premises registration, if they don't have a licensing manager.
So there's no.
We have to go through a DA.
So if a veterinarian is prescribing medications and they're providing veterinary services, we have complete authority over the care that's provided by that veterinarian. But there's not a place to go and inspect. So the minimum standards as it applies to a premises is not what we're looking at. But as far as the jurisdiction over the licensee of the care that's provided, the professional judgment of the licensee, medical record requirements, all of those still remain.
But not if there's unlicensed activity.
So if for unlicensed activity, we would go, just like we have the ability to enforce any other unlicensed activity, we can do investigations and do citations against unlicensed individuals.
Okay.
Out of state?
Yes, so if they are providing services to animals located within California, they have to be licensed in California.
Tara Welch, Board Counsel. I'm starting to get concerned about relying on the profession and standard of practice. If you are practicing through telehealth and you've established your VCPR because you've done like an annual exam, even, not just on the phone, because honestly, the telehealth doesn't actually require. If you look at the cut to the chase, if you establish the VCPR to determine that vaccinations are fine, and then I mean, how does this actually work telehealth wise? We've got, because that was the initial example. The animal was examined for health for vaccinations. And then a few weeks later, the owner reported diarrhea. So that could have been reported in a phone call. So technically that's telehealth because the animal was not brought back in person and the veterinarian didn't go to the location of the animal. But so maybe it was an email. Hey, diarrhea, what do we do? Bring in a stool sample. Stool sample is delivered. Why are we going to require a telehealth practitioner to have a brick and mortar for this scenario when what they're doing is appropriate? They're requiring diagnostic testing of the stool. They are determining, oh, Giardia, we're good. I'm going to issue a prescription by telehealth because even though I haven't examined the animal patient in person, I have checked boxes enough that, any other veterinarian in this location would have done the same, the standard of practice.
If I may, if you're doing just telehealth, you cannot do a fecal exam. You don't have the ability. That's why I'm saying if it's a fixed facility and they're doing telehealth, they can have the fecal sample dropped off and go from there.
Right. Or, at a facility that does testing, right? It could be the lab itself.
Well, that defeats
Then
the purpose because then they have another charge.
Okay, so as we're fleshing this out, someone who's practicing via telehealth has zero ability to obtain any diagnostic information or imaging. Is that correct?
I've heard of places either out there already or theoretically coming that are going to do just diagnostics for telehealth. I don't know if they exist yet. Do you know, Grant?
And are these facilities run by veterinarians? All right, that's interesting.
Okay, so my point here is just, being cautious of, how much we're requiring with respect to telehealth because we've got an entire community that is urging access to care. And if we start to cut it off because of how that practice is being done through telehealth, then we start to rein in access to care again, maybe unnecessarily when, for the case at issue here, diarrhea didn't really require a second visual examination. It just required some additional diagnostic information, which confirmed Giardia, which could easily be treated through a telehealth prescription. So, I'm just bringing this to your consciousness because this, telehealth is going to be used in ways that we're, sitting here right now, not thinking it's going to be used, but it will be. And maybe that is most beneficial to consumers because they can really start to get the access that they need. So, I don't know that continued restriction on requiring in-person premises exams is necessary. Perhaps just relying on the standard of care is more appropriate.
Suggested.
Yeah, obviously, this is complicated in a lot of ways that we're not even understanding yet. But I mean, personally, I would always prefer, and I trust the discretion and the professional expertise of the veterinarian in something like this. If there's been a VCPR established, this Giardia one is a little easy for me, it seems like, because, the vet saw the animal a month later or whenever it was, 5 weeks later, had the issue come up via email. The stool sample, we presume, of that animal was tested and drugs were prescribed and it worked. What I guess my concern is about releasing the condition specific, which I am inclined to do if there's been a valid VCPR, is and I don't know if you could tie it to this. What I worry about is sort of revolving medication where you make a diagnosis or a vet makes a diagnosis without a new VCPR, different condition, prescribes medication. It's not effective, then tries another medication, then another. I wonder about public protection and patient protection unless at some point there's a in-person VCPR required. And I don't know how you do that, but anyway, I assume a veterinarian would not do that. If it didn't work, they'd bring them in, but that's my hope.
Well, that's exactly my concern, and I have it even written here, is that I support removing the condition-specific language because I think, we're moving towards that and we have to rely on the veterinary judgment. However, I am extremely concerned for the potential for overprescribing. I am extremely concerned that they can never re-examine the patient and that the VCPR may not expire. So those things concern me heavily. And if we can find a way that we can resolve some of this and not, the potential for overprescribing, that's a huge consumer protection piece for me.
And I agree with that. As a consultant who's looked at many, many complaints, having this condition-specific VCPR, I do not think it's stopping those doctors one bit. Period. They're doing it. Whether this is something they get dinged for or not, they're doing it. So I don't see this specifically stopping the doctors that we are worried about being revolving doors. This isn't doing it. I'm pretty confident in saying that. So I think it's a concern for everyone, of course. But I don't think tying our hands with the condition-specific VCPR for the majority of good it's going to do, I don't think it's stopping what we are concerned about right now.
Anything further from the committee?
Can I just understand the consensus of the MDCs so we can report it back to the board? It sounds like the consensus is, yes, we want to look at removing the condition-specific language, potentially looking at a time frame, potentially a year that it would have to be reestablished, but also thinking about the concerns to preventing potential pill mills or the reoccurrence of prescribing and dispensing medications. Consensus?
I didn't hear the time frame number you said.
Oh,
She didn't into a time frame.
She didn't say a time
The
frame.
time frame, potentially 12 months, but just throwing that out there.
I mean, we talked about that's how, I know that it was brought up that that's how it was interpreted many years ago. And despite Nancy thinking that she's the only one in the room that remembers that, old enough to remember that, I actually was around for that as well in the Sue Garanon days. And so, yeah, I would not be opposed to a time frame. And I think that that's something that I would be very interested in discussing if we could do that.
Just for my own personal belief, I believe in the condition-specific VCPR, but it should be interpreted in a way that makes sense with, everyday practice. So like in the instance of this puppy, who was just seen a couple months before, and I think a fecal is part, to me, the condition-specific is not the giardia. To me, the condition-specific is the diarrhea. So say it didn't have diarrhea and the owner just brought in a routine fecal and it showed up with giardia. I think you'd be fine with sending home meds for that. And so you got an instance of you have a dog with lymphoma and you started on chemotherapy. and they call you a few days later and it's got vomiting and diarrhea. You're going to send home meds for that because you know it's related to the chemotherapy. In fact, some oncologists go ahead and send it home without even the dogs starting to show signs. But I don't know if you can write that into language that would make sense. And that's the problem.
Yeah, I think the, professional judgment is key here. We take our pets to a veterinarian for their professional judgment. We're trusting them to make a diagnosis, to prescribe the correct medications, but we're now not going to trust them to use their professional judgment to determine whether or not they need to see the patient again. I guess that's the way that I'm looking at this.
And also to keep in mind too, regardless of how they establish it in the first place. So they might establish that VCPR virtually, and then something goes wrong and they treat a new condition. They don't see hands on the patient. A subject matter expert might say they didn't have enough sufficient knowledge for that VCPR virtually. They should have had hands on the patient because of X, Y, Z in this. Then that would still be a violation of the standard of care, not specifically a violation of this statute. So you could still take action there if the professional judgment was lacking.
I think sometimes we get caught up in the bad actors, and we can't get caught up on bad actors.
Oh, shit, that's our job.
We have to remember that we have resources for bad actors.
As far as the time limit, so right now there's a 12-month requirement for controlled substances, but I think, if we do drop the condition specific, I think it should be 12 months for all medications, all prescription medications.
It should be.
Yeah, I think that's definitely something worth discussing moving forward. Okay, let's open it up for public comment in the room.
That was in our old language. That was in our old language before the new VC.
Hi, Grant Miller, CVMA. I heard a lot of really great comments up here. I heard a lot of really wrong comments up here too. Not wrong in the sense that I disagree with them, wrong in that they're factually wrong. But we'll deal with that on another day. So to put the cart way before the horse, but for reasons that I feel are constructive for this board, the CVMA will be sponsoring legislation this year to change California's VCPR requirement from being condition specific to being patient specific. Now, the reason why the cart is way out in front of the horse is because we don't even have an author yet. And my board just said it was okay for us to do it this last weekend. So I don't have a lot of the details really ironed out, but I do feel it's important for your board to know because we would like to maintain a collaborative working relationship with you on this. We feel like you have good insight and great conversations to be had about this that can help contribute to constructive language, because this will be a statutory change. And anytime we're changing the VCPR, that's like doing open heart surgery on the veterinary profession. So we want to get it right. With that said, we do already feel that the 1-year in-person exam would need to be maintained to have a valid VCPR. We've already gotten that far. But we also feel like that would also need to be maintained as 6 months for telemedicine, because telemedicine law already states that. And we're not really interested in really delving into telemedicine as much as we are, like Christy said, there's always going to be bad actors. We're not really looking to legislate to the lowest common denominator. We're looking to do what Marie said, what Dr. Gedkin said, what has been said up here multiple times, which is to leave the discretion to the veterinarian in each condition to decide what is appropriate. Remember also that in telemedicine law, there are 2 provisions baked into that law that are really guardrails. One of them says that veterinarians are held to the same standard of care as if they were seeing the animal in person. The other one says that the veterinarian has to inform the client as to whether or not they believe telemedicine is appropriate for the condition that the client's presenting. So there are a few things in there that can kind of help the veterinary medical board with that standard of care fight that's going to happen with telemedicine, bad actors, so to speak. But that's tangential to the concept, I think, of the patient-specific VCPR. In response to Dr. Sullivan's comment that, for for in-person VCPR, we're going to want to, let it be patient-specific, but for the telemedicine, it should be
15 seconds.
condition-specific. That will never happen. The veterinary profession is under the impression right now that we have a patient-specific VCPR in the state of California. I've fought that for the 20 years I've sat in this regulatory chair and helped try to explain to them that's not actually the way it works. But the reason they feel that way is because that's the way it works in the rest of the country. And that's the way all the schools teach it, and that's the way we've come to understand it. That's actually the way that this board used to do it. So to say, well, okay, now we're going to teach you condition specific for this one and that, it just looks punitive against telemedicine. The idea of a premises permit is really minimum facility standards and record keeping. That doesn't really lend to, it helps standard of care, but it doesn't really lend to standard of care in a doctor's professional decisions on what they should do with an animal patient. If the doctor is going to do it wrong, they're going to do it wrong, whether it's in person or whether it's on telemedicine. And those bad actors will always be there. And for that, this board has subject matter experts to help determine standard of care. So as we move forward, I value so much the telemedicine type discussion, but I do want to be careful in making sure that we're not conflating two separate issues. I know that not everyone likes telemedicine, even though this board supported it. And that, we have that law there, it's going to stay there. That was made very clear to us by our legislature, and there you go. So in moving forward, we are looking for that access to veterinary care solution. And we're looking to help our veterinarians make better decisions about what they think they can do safely with their animal patients, with seeing them or without seeing them. And they can make that decision based on that first VCPR that they establish at least once a year in person and at least every 6 months by telemedicine. And from there, standard of care will prevail, and this board will successfully work those cases as they come in. I look forward to keeping you informed and hope that if we do get a bill, that this board will be active in their participation and contributing to the language, because I believe that your knowledge can only make the language better. Thank you.
Bonnie Lutz. I want to echo what Dr. Miller said, and I don't want to be duplicative, but I will just tell you that over the years that I've been doing this, I have answered the question so many times about this condition-specific requirement. And my answer always is, it's condition-specific, but look at it as a standard of care issue. It really is a standard of care issue. And I have to emphasize all the time to my clients and people who hire me as a consultant that we're looking at a practice act, but we're also looking at the standard of care. And those two things have to be looked at together. So if you see a dog for a lameness issue and are treating that lameness issue, and 6 months later, he has no hair on his back, you need to see him again. I mean, that's a different condition than the lameness situation. So I really strongly recommend that you do remove that condition-specific requirement, because nobody really understands it anyway. Also, there is not another state that has a condition-specific VCPR, and I review them yearly for a large client, so I know that nobody has changed it recently. But again, I just emphasize that the standard of care is the most important thing to look at overall, and I also agree with Grant that if you are going to remove the condition-specific, frequently veterinarians think that there's a 1-year limit on the VCPR, and that's really not the case in California. It is the case in several other states. So I would highly recommend that if you do remove the condition-specific requirement, that you make it clear that the VCPR lasts for a year when done in person and 6 months when done with telehealth. Thank you.
Seeing no further public comment from the room, moderator, will you please open it up for public comment online?
All right, we are accepting public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment? Seeing no request online, do you wish to continue?
Yes, thank you. Okay, we are going to take a 15-minute break. We will come back at 3:20. Okay, welcome back. Just a few more ongoing subcommittee topics to briefly touch on for the Veterinary Practice Subcommittee. We have absorbed the CDFA subcommittee into this subcommittee. So there's still a collaborative effort to meet with the California Department of Food and Agriculture. We were scheduled to have a meeting on October 10th. However, that meeting was scheduled to October 17th. So we don't have an update for that at this time. We're also working on mandating electronic medical records. This discussion around that. The board tasked the MDC with researching whether the board should transition to requiring all medical records to be maintained electronically. This has been assigned to this subcommittee, and the subcommittee anticipates multiple meetings and significant stakeholder engagement before bringing this topic to the MDC and the board. Okay, agenda item 8. Update and discussion from the Enforcement Subcommittee, Dr. Gedkin and Dr. Waterhouse.
Thank you. And we are going to start with this chart, would probably be the most helpful to follow. As indicated in this chart, from January 2025 through September 2025, consultants reviewed 593 cases, of which 315 were determined to be no violation. 17 were found to be educational opportunities, 16 had insufficient evidence, and 245 of those consultant case reviews were determined to need a full expert review. The last point is important as it shows that 41% of cases reviewed by a consultant are then forwarded to an expert, meaning our consultants can filter the majority cases and get them closed more quickly. From January 2025 through September 2025, experts reviewed 286 cases, with 102 of those being closed as no violation. 121 were closed with an educational letter, 22 had to be closed due to insufficient evidence or other. 13 of the cases were related to citations for 6 respondents, and 28 cases were related to disciplinary actions for 11 respondents. This demonstrates that 86% of cases closed involving an expert review did not result in a citation or discipline. It should be noted that the average number of cases reviewed monthly by experts is around 32 cases, and the average number of cases reviewed by consultants is 66. The number of cases reviewed dropped a bit in September due to availability issues with some consultants, as well as large case groups assigned to multiple experts in August, which were not finalized. The number of cases pending consultant and expert review has increased since the last board meeting, 913 and 706 cases respectively, as board staff is proactively requesting records for all cases. This number will continue to rise as many of our pending complaints haven't had their records requested yet, but will. Roundtables were held on August 27th and for the consultants and August 28th for experts. The consultant roundtable had 5 attendees and the expert roundtable had 11. During these roundtables, a variety of report writing topics were covered, including avoiding references to other unrelated cases when writing reports, jargon, artificial intelligence, making assumptions on behalf of the respondent, providing personal opinions of the respondent, and opining on non-medical issues. Reminders that experts are required to have 5 out of the prior 7 years of clinical hands-on experience in the area in which they are opining. Each standard of care finding should exist on its own. Failure to perform is different from failure to document, and all medical issues present in the record should be identified. In addition to these, there were discussions on condition-specific language, veterinarians working with a specialist and the application of the VCPR, overtreatment, antibiotic stewardship, responsibilities of a veterinarian when firing a client, use of waivers, and inappropriate administration of drugs. The subcommittee reviewed 6 finalized cases to identify praise and opportunities for improvement to relay to the expert who opined on the related case. Of note was the comment from the subcommittee noting that the expert had done an amazing job. The subcommittee also identified a few opportunities, such as taking note of autocorrect and spelling mistakes, listing out medical record departures in a more organized way, standard of care concerns versus medical record omissions, calling out a failure to discuss diagnostics, noting findings from a medical record versus complaint allegations, improper treatment versus improper diagnosis, concern over the use of PenG and dosages of metronidazole. Quarterly case reviews will continue, provided there are finalized cases from active experts for the subcommittee to review. And then we had a meeting on September 4th to discuss the MDC memo contents and an update on the following. Strategic Plan Objective 3.4 is aimed at increasing the number of experts and consultants to decrease investigation processing times. One task to help meet this objective is to create a video to recruit additional experts to join the team. Board staff met with DCA's public affairs team in September and is in the process of crafting video scripts. However, due to staffing issues, the public affairs team noted that videos will likely not be able to be completed until Q1 of 2026. Strategic Plan Objective 5.4 is tied to that goal. The goal is to increase videos demonstrating how to file a complaint and apply for a license or permit. During the board's meeting with DCA's public affairs teams, these additional videos were discussed and a plan is being laid out to create them. As far as inspector recruitment, the subcommittee discussed the possibility of employing veterinary assistants to conduct premises inspections given the reimbursement rates for inspections. It was also determined that any complaints submitted by a licensed veterinarian would automatically be shifted into the expert queue rather than having them filtered by a consultant. And pursuant to Strategic Plan Objective 3.7, the subcommittee finalized updates to the hospital standard self-evaluation checklists to help licensees remain in compliance with regulations. Since the MDC's July 2025 meeting, the checklists were finalized and sent to DCA Legal for review and approval. Upon approval from legal, staff will work with the publications design and editing team to develop the checklists for posting on the board's website and dissemination to stakeholders. The subcommittee and staff are also creating checklists to coincide with minimum standards for alternative veterinary premises regulatory package that is anticipated to go into effect January 1st, 2026. By starting to update the checklists before the regulations go into effect, the subcommittee strives to have those checklists ready for dissemination upon the regulations' effective date.
Anybody have any questions for them? Christy? I have a question, just, it references to other unrelated cases when writing reports. What is that in regards to? Yes, thank you, Dr. Waterhouse.
You can ask Tara, but as I recall, that reference to, say you wrote a report on how a dog was treated for lymphoma or how a veterinarian was disciplined in case number A. If you're working on case number B, case number A has nothing to do with it, even though you can't reference, well, in case number A, we did this and this and this. The two cases are totally separate.
Anything else from the committee? Okay, we will open it up to public comment from the room. Seeing none, moderator, would you please open it up for public comment online?
WebEx is open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request, do you wish to continue with the agenda?
Yes, thank you. Okay, agenda item 9, update and discussion from the outreach subcommittee. Kathy Bowler and Dr. Waterhouse.
Yes. Yes, it was great. On September 23rd, Jessica came to Fresno and spoke to my local VMA, the Central California VMA. And she gave a talk on the spectrum of care, which is kind of part of the access to care. I chimed in a little bit, but she did most of the speaking, and it was well attended and appreciated. So thank you.
That's it.
Anything else?
Any questions from the committee? Any public comment from the room? Seeing none, moderator, would you please open it up for public comment online?
WebEx is open for public comment on agenda item at 9. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a moment now to see if we have a request for public comment. Seeing no request, you wish to continue with the agenda?
Yes, thank you. Okay, future agenda items and meeting dates?
All right, so for future agenda items, we have, as mentioned before, transitioning to requiring electronic medical records, which the veterinary practice subcommittee is looking at. There was one that came from the board meeting, future agenda items at the last board meeting, looking at pharmaceutical pricing and its impact on access to care. This stemmed from some public comment that was raised about unfair pharmaceutical practices affecting care access. The board's role was unclear, but the board members agreed it impacts to consumer protection, that there are impacts to consumer protection and would like the MDC to research and collaborate with agencies like the Better Business Bureau. And that's kind of all the guidance provided, but it's something that the board would like the MDC to at least research and report back to. So that is coming. They're also looking, as previously mentioned, on the electronic signature requirements and whether or not there should be some changes in laws or just clarification and outreach provided to licensees. There's what we talked about today with the high quality, high volume spay and neuter clinics and the alternate premises regulations. We have the VCPR condition specific language that we'll continue to work on. And then potentially based on direction from the board tomorrow, likely the licensing manager requirement will be punted back to the MDC to further discuss, potentially creating limited licensure to address the shelter concerns, whether that's reciprocity or foreign graduates. And then the VCPR requirement for high quality, high volume spays and neuters that was briefly discussed today. So this could be coming from the board. And that's it that I have so far. So any additional items?
Anything else that we need to add?
And then our meeting dates we have posted online is January 20th of 2026, April 14th, July 14th, and October 13th. Sure. January 20th, April 14th, July 14th, and October 13th.
Okay, any public comment from the room? Seeing none, moderator, would you please open it for public comment online?
We are open for public comment on the meeting dates. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a moment now to see if we have a request for public comment. Seeing no request, you wish to continue with the agenda?
Yes, thank you. Okay, item 11, election of 2026 committee officers. Dr. Sullivan?
Yes, I nominate Cheryl Waterhouse for chairman.
I'll second.
Dr. Waterhouse, do you accept the nomination?
Yes.
Okay.
Now a second.
Any discussion?
Discussion on that? Okay,
Public comment?
public comment from the room? Okay, seeing none, moderator, would you please open it for public comment online?
We are open for public comment on the nomination for chair. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no request, you wish to continue with the motion?
Yes, thank you.
Dr. Sullivan?
Yes. Trying to keep me awake or something?
Yes, I am trying to keep you awake. Ms. Essery?
Yes.
Ms. Bowler?
Yes.
Dr. Getkin?
Yes.
Dr. Nunez?
Absolutely, yes.
Ms. Blaski?
Yes.
Ms. Shefelt?
Yes.
Dr. Solcito?
Yes.
Dr. Waterhouse?
Yes.
Motion carries.
Okay. Congratulations. I would like to nominate Kathy Bowler for vice chair.
Ms. Bowler, do you accept the nomination?
I do.
Then I'll second.
Any discussion? Public comment from the room? Seeing none, moderator, would you please open it for public comment online?
We are once again open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no request, you wish to continue?
Yes, thank you.
Ms. Essery?
Yes.
Ms. Bowler?
Yes.
Dr. Getkin?
Yes.
Dr. Nunez?
Yes.
Ms. Pulaski?
Yes.
Ms. Shefelt?
Yes.
Dr. Solcito?
Yes.
Yes.
Dr. Sullivan?
Yes.
Dr. Waterhouse?
Yes.
Motion carries. Congratulations.
All right, congratulations and meeting adjourned.